But apart from that, thank you all for coming and welcome to session 3. This is Mediccom, our healthcare society that sort of branches out to other schools so you can work in PBL groups to make presentations on certain topics. Today's topic is obviously autoimmune diseases, so I'm just going to run through the schedule of what today looks like. So at 11 o'clock, we have our first group on presenting on multiple sclerosis, then group 2 on psoriasis, and then at 12 o'clock we have lunch. At 1 o'clock, group 3 is presenting on Guillain-Barre syndrome. Group 4, celiac disease. Group 5, autoimmune vasculitis. Then at 2:30, we have a guest speaker from the charity, which is AIMS, which stands for Autoimmune Multiple Sclerosis. And she's going to be talking to us about their mission, what they are trying to raise money for, and how COVID has impacted the autoimmune community. So it'd be great if you could ask some questions in the Slido that is on the chat box as well. The link for the charity to donate is in the chat box as well, so please do so. Obviously, it would help them out a lot, and they are helping us with this event. And then I think that is pretty much all of what's happening today. And then at the end, we'll introduce the next session. Please do follow us on Instagram as well. Let me quickly check what is our username, just for you all to know. It is, Mediccom Healthcare Society. We'll be adding some interesting features to our Instagram in the coming weeks, so it'd be great if you could get involved with that as well. And yeah, that's pretty much all for now. We also have our judge for the morning session, who is Dr. Nikita. She's an F tutor in Gen at the moment, so she's got a wide understanding of what you're all going to be presenting on today. So I'm going to pass on to Arian because he's got some things to tell you about the business side of Mediccom, so I'll just let him explain.
All right, can you all see my screen?
Yeah.
All right, so as Namita mentioned, this is our Just Giving page for autoimmune diseases. So please donate here. You can just press Give Now, and it should take you to the donate link, which is pretty easy. I don't think it's that difficult. You may have to make an account, which is pretty quick. Next, I want to highlight this, which is our new Google Business for Mediccom Healthcare Society. And we have been trying to get reviews on our website through the use of our post-event Google Forms. However, the best thing to do now is go down to this section, press Write a Review, and it should take you to a separate account where, it will go to my sign-in, but it should take you to an account where you can write a review. And that would be really helpful for our society, as this Google Business will be bumped up, and then we can get more insights and more people joining the society. And hence, Mediccom will grow, and you'll have more presentations and more things to look forward to. Next, I'd like to address Mediccom as another business on LinkedIn. And we've started this in order to reach out to different medical professionals and yourselves in future time, as if you were Mediccom alumni, so to speak. So feel free to follow this, and we'll post different links to the charity and things like that. This has already been viewed by different people in different universities, such as UCL and Queen's Mary. And we believe that hopefully that this society can grow to an extent where we can reach out to different doctors and different subspecialties all across the UK. So yeah, you can use this to your advantage however you like. That's all I have to say. So please write a review, and please follow us on LinkedIn, and please donate. Thanks.
So I think we'll just wait 5 minutes until group 1 can start, okay? Presenting on multiple sclerosis. Good luck.
Good morning, everyone. My name's Akash, and I'll be presenting the topic of multiple sclerosis today. Although Till can't be here today, we both work together to make this presentation, and I'll also cover his sections. These are the areas I'll be covering today, so pathophysiology, diagnosis, current treatments, complications, some statistics, and ethical concerns. Multiple sclerosis, or MS, is an autoimmune disease which affects the brain and spinal cord. In MS, the immune system mistakenly attacks the layer that surrounds and provides protection to the nerves, known as the myelin sheath. It can cause a range of symptoms, including problems with vision, sensation, balance, and arm or leg movements. As for the structure of nerve cells, neurons, also known as nerve cells, send and receive signals from your brain. Neurons vary in size, shape, and structure depending on their role and location in the body. However, almost all neurons have three essential parts: a cell body, an axon, and dendrites. Also known as a soma, the cell body is a neuron's core. The cell body carries genetic information, maintains a neuron's structure, and provides energy to drive activities. Like other cell bodies, a neuron soma contains a nucleus and specialized organelles, and it's enclosed by a membrane which both protects it and allows it to interact with its surroundings. An axon is a long tail-like structure which joins a cell body at a specialized junction called the axon hillock. Neurons generally have one main axon. Dendrites are fibrous roots that branch out from the cell body. They receive and process signals from the axons of other neurons. Many axons are insulated in a fatty substance called myelin. Myelin helps axons transmit electrical signals over longer distances and efficiently. The three main characteristics of MS are the formation of lesions in the central nervous system, inflammation, and destruction of the myelin sheaths of neurons. It's not fully understood how these features interact to produce a breakdown of nerve tissue, and MS is believed to be an immune-mediated disorder developing from the interaction between an individual's genetics and unidentified environmental causes. Damage is thought to be caused by a person's immune system on their own nervous system. The name multiple sclerosis refers to the sclerae that form in the nervous system, most often the white matter in the optic nerve, brainstem, basal ganglia, and spinal cord. MS involves the loss of oligodendrocytes, which are cells that create and maintain the myelin sheath. The loss of these cells results in partial or complete demyelination, in turn leading to the breakdown of the exposed axons of neurons as the disease advances. Apart from demyelination, the other sign of MS is inflammation. This can be explained immunologically, with the inflammatory process being caused by T cells. The T cells mistakenly recognize myelin as a foreign and attack it, and this attack starts a process of inflammation, triggering other immune cells and releasing soluble factors. There are many different symptoms of MS, and these can vary in severity in different patients. Some symptoms include fatigue, vision problems, numbness or tingling, muscle spasms and mobility problems, sexual problems, pain, cognitive impairment, bowel and bladder problems, and finally speech and eating difficulties. A variety of risk factors for MS are hypothesized. However, there are varying levels of evidence for each of these, and some have exceptions, leading to the possibility of different conclusions. Firstly is geography. MS is more common amongst people who live further away from the equator, with some exceptions being certain ethnic groups. Since MS is more common in regions with Northern European populations, the geographic variation may simply reflect the global distribution of these higher risk populations. Next is genetics. Although MS is not thought to be a hereditary disease, there are some genetic variations that have been shown to increase the risk. For instance, the chance of developing the disease is higher in relatives of an affected person. This can be seen in identical twins, with a 30% chance that they are both affected, 5% in non-identical twins, and 2.5% in siblings. Furthermore, if both parents are affected, their children are at 10 times the risk compared to the general population. There are some other possible factors, which include smoking, stress, vaccinations, diet, and hormone intake, which have been studied in the past. However, most of these studies don't show an association. Diagnosis of multiple sclerosis usually begins when a patient or someone close to the patient notices some of the symptoms. The GP will then take a history, noting the type and pattern of symptoms to help determine whether the patient might have MS. Common presentations of MS are loss or reduction of vision, double vision, problems with balance, and altered back and limb sensation. Before referral to a specialist, alternative diagnoses are ruled out by performing blood tests, such as full blood count, inflammatory markers, for instance, erythrocyte sedimentation rate, C-reactive protein, liver function tests, renal function tests, calcium, glucose, thyroid function tests, vitamin B12, and HIV serology. If a GP suspects a patient has MS, they'll make a referral to a specialist. In this case, that's a consultant neurologist. The neurologist will use a McDonald criteria, with the latest revision being from 2017 to diagnose MS. This criteria combines clinical, laboratory, and radiologic evidence of lesions at different times and sites. The diagnostic tools used by the neurologist include a neurological examination to check for abnormalities in vision, eye movement, hand and leg strength, and balance and coordination. Neuroimaging techniques such as MRIs are used to find areas of demyelination. The element gadolinium can be administered intravenously to increase the contrast in these images to find active plaques. A lumbar puncture is a procedure to remove a sample of spinal fluid using a needle inserted into the back. The sample can then be tested for immune cells and antibodies, signaling the immune system has been fighting a disease in the brain and spinal cord. Finally, an evoked potential test can be used to assess how well the eyes work. Light patterns are shown to the eyes, while the patient's brainwaves are monitored using electrodes attached to the head. Once a diagnosis of MS has been made by the neurologist, the type of MS may be able to be identified using the pattern of the symptoms and results of the MRI scan. At the moment, there is no cure for MS, but there are a number of treatments that can help to contain the condition. The specific treatments that you obtain will be dependent on the specific symptoms that you have. Treatments can be separated into symptomatic treatments, treatments for MS attacks, treatments to modify progress, and lifestyle and home remedies. Symptomatic treatments range from therapy to medications. An occupational or physiotherapist will teach stretching and strengthening exercises to help patients perform daily tasks. Mobility aids such as a cane, walker, or wheelchair may also be useful. To help manage leg weakness, patients can do stretches to maintain mobility and prevent muscle spasms. Strength and conditioning exercises, such as leg lifts, can be incorporated to improve balance and coordination. Muscle relaxants are useful if a patient experiences painful or uncontrollable muscle stiffness or spasms, particularly in the legs. Muscle relaxants, such as baclofen, tizanidine, and cyclobenzaprine, may help. Muscle relaxants work by causing the muscles to become less tense, which in turn reduces pain and discomfort. They do this in different ways. Baclofen, diazepam, methocarbamol, and tizanidine act on the central nervous system, which is a brain and spinal cord, whereas dantrolene works directly on the muscle. The most common medication used to increase walking speed in MS patients is dalfampridine. Dalfampridine is in a class of medications called potassium channel blockers. It works by strengthening the signals sent by the brain through nerves that have been damaged by MS. These signals that have been strengthened will help the patient to improve their coordination when walking, which then subsequently leads to an increase in the speed the patient walks. Amantadine, modafinil, and methylphenidate work to reduce MS-related fatigue. Some drugs used to treat depression, including selective serotonin reuptake inhibitors, may also be recommended. How these medications reduce fatigue in MS patients is not fully understood, but it's thought that the treatment acts on the brain by increasing the release of the neurotransmitter dopamine and boosting the brain's response to another neurotransmitter called norepinephrine. Both dopamine and norepinephrine control how sensitive the brain is to nerve signals. Therefore, it's possible that the combination of more dopamine and a stronger response to norepinephrine is responsible for the decrease in fatigue that's experienced by some MS patients who use amantadine. The two main treatments that are used to counteract MS attacks, which involves an exacerbation of MS, also known as a relapse, attack, or flare-up, are corticosteroids and plasmapheresis. Corticosteroids are steroid hormones produced in the adrenal cortex or made synthetically. They suppress the multiple inflammatory genes that are activated in chronic inflammatory diseases by reversing histone acetylation of activated inflammatory genes through binding of liganded glucocorticoid receptors, or GR, to coactivators, and recruitment of histone deacetylase 2, HDAC2, to the activated transcription complex. At higher concentrations of corticosteroids, GR homodimers also interact with the DNA recognition sites to active transcription of anti-inflammatory genes and to inhibit transcription of several genes linked to corticosteroid side effects. Plasmapheresis, also known as plasma exchange, is when the liquid portion of your blood, or the plasma, is removed and separated from your blood cells. The blood cells are then mixed with the protein solution, which is albumin, and put back into your body. Plasma exchange may be useful if your symptoms are new, severe, and haven't responded to steroids. This is a successful method for treating some autoimmune diseases because it removes the circulating antibodies that are thought to be active in the diseases. Although studies of plasmapheresis as a disease-modifying treatment for MS did not find the procedure to be effective, studies do indicate that plasmapheresis may be beneficial for individuals experiencing a relapse that has not responded adequately to corticosteroids. In terms of lifestyle and home remedies, it's important to get plenty of rest, and so sleeping habits may need adjusting. To make sure you're getting enough sleep, you may need to be evaluated and possibly treated for sleep disorders such as obstructive sleep apnea. If you have mild to moderate MS, regular exercise, such as swimming, can improve your strength, muscle tone, balance, and coordination. Other types of mild to moderate exercise recommended for people with MS include walking, stretching, low-impact aerobics, stationary bicycling, and yoga. In some people, a rise in body temperature may worsen MS symptoms, and avoiding their exposure to heat and using devices such as cooling scarves or vests can be helpful. Since there's little evidence to suggest a particular diet, experts recommend a generally healthy diet. Research suggests that vitamin D may have potential benefits to people with MS. Finally, stress may trigger or worsen symptoms. Yoga, massages, meditation, or deep breathing may help. Currently, treatments for MS involve taking a type of medication or experiencing a therapy-based program. Many medications given by doctors for MS treatment have multiple side effects which can affect susceptible patients. To minimize the risk of muscle relaxants, the doctor should be informed of any history of seizures, liver disease, and any other medical conditions or concerns. Women should inform their doctors if they're pregnant, plan to become pregnant, or are breastfeeding. Since muscle relaxants are total body relaxants, they typically induce tiredness. As a result, it's not safe to drive or make important decisions while taking muscle relaxants. Muscle relaxants are often suggested for evening use due to their sedative effect, and drinking alcohol can be especially dangerous when taking them, as the sedative effect of the medication is intensified with alcohol consumption, and combining the two can be fatal. Muscle relaxants have a risk of misuse and abuse. Some muscle relaxants, such as cyclobenzaprine, can be habit-forming on their own. Others may be taken with other drugs, creating a high, and are therefore more likely to be abused. When using fatigue-reducing medication, serious adverse effects include neuroleptic malignant syndrome, psychosis, suicidal ideation, and CNS depression. Patients should be advised against activities that require physical and mental alertness, such as driving, and avoid combination with other CNS depressing agents, such as alcohol. Dalfampridine may cause seizures, meaning that patients should report any convulsions or seizures while taking the medicine to their doctor. This medicine may cause serious allergic reactions such as anaphylaxis, which requires immediate medical attention. Therefore, the doctor should be informed right away if a patient has a rash, itching, hoarseness, trouble breathing, trouble swallowing, or any swelling of their hands, face, or mouth after using the medication. Oral corticosteroids affect the entire body instead of one particular area. This route of administration is the most likely to cause significant side effects. Side effects depend on the dose of medication you receive. When using an inhaled corticosteroid, some of the drug may be deposited in your mouth and throat instead of making it to the lungs. Now, plasmapheresis can cause faintness during plasma exchange. Changing your position so that you're lying down will usually mitigate this. Numbness or tingling around your mouth, nose, and fingers may also be felt during retreatment. This is a side effect of a substance called citrate. Citrate is mixed with your blood to stop it clotting while it's outside your body. If the amount of citrate builds up, it can lower the levels of calcium in your body for a time and cause numbness or tingling. With interferon beta medications, most people have flu-like symptoms such as headache, tiredness, fever, chills, and muscle aches when they first start on the medication. These symptoms usually persist for a day after the injection and improve after a few months of continued use. These side effects are lessened by injecting the medicine before sleeping and by using pain relievers such as ibuprofen before each dose. Common side effects of glatiramer acetate include injection site reactions such as lipoatrophy, leading to permanent indentations in the skin, redness, swelling, itching, or some pain at the site. Some people may also experience a reaction known as immediate post-injection reaction, or IPIR, which may result in chest tightness, shortness of breathing, and palpitations. Emerging treatments for MS. Siponimod was approved by the FDA in 2019, and this tablet is approved for relapsing, remitting, and secondary progressive forms of MS. It's an immune-modulating therapy that helps reduce both relapses and progression of disability. Cladribine is another tablet to treat relapsing, remitting, and secondary progressive forms of MS. In clinical trials, cladribine reduced the progression of disability and significantly reduced relapse rates. Because of safety risks, cladribine is generally used when people can't take other drugs for MS or when those drugs aren't effective. Ocrelizumab is a drug that reduces relapse rate and risk of disability progression in relapsing, remitting MS. It's also the first DMT to slow the progression of primary progressive form of MS. Stem cell transplantation is also being evaluated to treat MS. Researchers are exploring whether destroying the immune system and then replacing it with transplanted stem cells can, in a way, reset the immune system in people with MS. For analytics, MS is estimated to be prevalent in 190 cases per 100,000, with 105,580 in England. MS is more than twice as likely to form in females than males, at 270 versus 106 per 100,000 population. 75% of males and females with MS are aged between 40 and 74 years of age. MS estimated incidence of between 8 and 11 new cases diagnosed each year in England per 100,000 populations. On average, 4,950 new cases of MS are diagnosed each year in England alone. Females in the 50 to 59 years age group are 3 times more likely than males of a similar age to have MS, 578 and 184 per 100,000 respectively. The highest prevalence for MS occurs in the 60 to 69 years age group for both sexes. female 598 and males 228 per 100,000 population. Smoking rates among males with MS are likely to be higher than those in the general population, and males and females with MS are more likely to be ex-smokers than males and females in the general population. Awareness. As far as charities are concerned, there are multiple MS-related charities based in the UK. The most well-known are MS UK, MS Society, and MS Trust. There are also helplines you can contact, such as MS UK is one. Hospitals. The MS service of a National Hospital for Neurology and Neurosurgery in central London contain its own MS clinical service with close links to UCL's Institute of Neurology, which forms the largest site centre for neurology and neurosurgery in the UK. Special events. There are multiple occasions throughout the calendar year that people are a part of to raise awareness for MS. There is the MS Awareness Week, which lasts from March the 7th to the 13th, 2021, which involves people sharing their stories about having MS. And there is also World MS Day, May 30th, 2021, which unites individuals and organizations from around the world. Multiple sclerosis is a disease that follows a variable and uncertain course. It can affect every aspect of the lives of patients and their families, which gives rise to a plethora of ethical problems for patients, families, and caregivers. Some of these issues are when and how to tell the patient the diagnosis decisions, various aspects of medical management and drug trials, concerns regarding quality of life, the effects and consequences of cognitive and psychological impairment, and finally, end-of-life issues. Ethical issues may also arise for the patient in relation to work and the environment and to the impact of a disease on the family. Throughout this whole process, communication skills and empathy are vital for a doctor to effectively convey information to the patient. And it's also crucial for doctors to refer to the 4 pillars of medical ethics when faced with moral issues in complex cases such as MS, which are autonomy, beneficence, non-maleficence, and justice. Thank you for listening to this presentation. I hope you all have a better understanding of multiple sclerosis, and I'd be happy to answer any questions.
Thank you, Akash. That was a great presentation. I've made a lot of notes and learned a lot. Can I introduce Dr. Nikki for her comments on the presentation?
Hi guys. Hi Akash. Very well done on your presentation. This was, like Arian said, very, very useful, very detailed. It looks like as if you and Tillai have done quite a lot of research looking at various sources for figuring out what MS is all about. And I'm sure everybody who's been listening, along with Aryan, have been taking notes, and this is really useful for everybody who's listening here today. It was actually really useful for me as well, because you guys have gone into quite like an in-depth research into the latest treatments and what's available, which some of which I wasn't even aware of. So very well done, and well done on like doing the whole presentation by yourself as well. I know it couldn't have been easy for you just with Tillai doing half the work, but yeah, you've done really, really well. Yeah, so I'd probably ask, because there's a lot of people here who are just learning about MS, and obviously, it was a lot of information in the last 20-25 minutes, which was really useful. But Akash, how would you want to summarize, like in a sentence or two, about what you think MS is about, to the guys who are obviously listening, and to someone who you just have to just say out in fresh? Do you want to give it a try and see what you come up with?
Yeah, sure. So MS affects your muscles and ability to move your body. It attacks your brain and spinal cord, and causes sclerosis, which is obviously lesions, and scarring or hardening around nerve cells. And while MS is an autoimmune disease, which means the immune system attacks your own body, and specifically the nervous system in this case, and causes what's hypothesized to be demyelination, which is a destruction of the myelin sheath around neurons. And while that causes the axons to be exposed and electrical signals can't be sent as efficiently around the body, and that in turn leads to a whole host of problems, as I've mentioned. So balance, cognitive, sexual mobility, it's extremely wide-ranging and quite debilitating, in fact. So yeah, I think it's important to spread awareness of the condition. And yeah, there's lots of research which is currently ongoing, which are looking quite hopeful for the future.
Yeah, definitely. Well done. That's essentially what it is. Like, it's an autoimmune condition. It's just like an attack on your own body cells. So the immune system is recognizing your body as foreign and attacking it, causing these various symptoms. And that is essentially, the theme of, today. And MS is one where the nervous system gets attacked. And also in the treatments that we were looking at, you said some of the immunosuppressive therapy was for secondary progressive and relapse and remitting MS. Do you know what that means, or what the types of progression in multiple sclerosis is? It's okay if you don't. Like, I just thought if you do.
Well, MS is one of those conditions where your condition gradually gets worse, unfortunately, as a disease progresses. And secondary progressive means that it's a stage of MS which comes after relapsing remitting MS, specifically.
Yeah, exactly. Well, yeah. There's different types of MS, and like you said, it's like a gradually progressive, gradually debilitating condition. Different people have different levels of ability or disability with MS. And like you said at the very beginning, the symptoms are relatively mild and very non-specific. Yeah, they might come with pain or a lot of loss of sensation or difficulty swallowing or lots of eye problems like pain on eye movements, which is called optic neuritis, or double vision. And they can come at they all can come at very different points in time and separately or all together as well. So that makes it really difficult to diagnose and for the GP to sort of put all that together. But yeah, as the disease progresses, you can either have, the symptoms gradually getting worse and worse and worse, that the person can't carry on with their daily activities. So just like a linear progression is the primary progression. And the relapse and remitting that you were talking about is basically when you get a sudden worsening of your symptoms, whatever they may be, that might be debilitating. So then we give some treatment like the steroids you were talking about, and then they come back to their normal function. And then, it goes on, and then again, they get another relapse, and then give some steroids or whatever treatment, and then it goes down. So that's kind of like a relapse and remitting. Again, that will also be like a progressive sort of like stepwise deterioration. So there's several graphs if anyone's interested as to how things progress on from time. But yeah, so essentially the take home for that is that there's different levels of ability and disability. It can progress gradually, or sometimes acutely, and then remit. But it is a chronic condition, chronic autoimmune condition that is sort of life-changing for the person. So like you were talking about, ethical issues as well, and communication, those things are really important for these kind of patients. So yeah, that's something that not just doctors, but psychologists, physiotherapists, occupational therapists are all involved in, to try and cause the least level of detriment to the person, whoever is suffering with MS. So yeah, if anybody's interested, just Google types of MS and look at the various different types of graphs, which just gives you like the level of disability and gives you an understanding of how variable the disease can be at different stages. So that's something to consider when you're thinking about MS. So that's why awareness, it always starts with awareness, and ensuring that people are understanding not just about the disease, but what the disease involves and can have potential of. So yeah, well done, Akash. This is a great start to the day.
Thank you.
Okay, so thank you, Nikki, for the feedback. And Akash, just before we finish with your presentation, there's 2 questions on the Slido. So the first one says, can you explain the difference between MS and ALS?
Okay, sure. So MS is an autoimmune disease, and that causes the body to attack itself. And whereas ALS is a nervous system disorder that wears away nerve cells in your brain and spinal cord. So MS causes the body to attack the myelin sheaths of the neurons in the brain and spinal cord, whereas ALS breaks down the actual nerve cells in the same locations.
Okay, and the second question is, what other subspecialties work with MS?
So the main specialty is obviously neurology, and it's a consultant neurologist working. However, in the initial diagnosis stage, a general practitioner is also involved. In the treatment, there's pharmacists, there's occupational therapists, physiotherapists, and also to take the MRI scans, radiologists are also required. So, yeah.
Perfect, thank you. Okay, so I'm going to pass it on to Arjun. He's going to introduce the next group. So thank you, Akash, for your presentation.
Okay, so the next group is group 2, who will cover psoriasis, and the speakers are Niana, Elisa, Brittager, Mahik, and Ruheimer. So take it away.
Good morning, everyone. Today we're going to be talking about the autoimmune condition that is psoriasis. So psoriasis is a chronic inflammatory skin disorder affecting approximately 2% of the population. It's a common skin disorder characterized by local formation of inflamed raised plaques that constantly shed scales derived from excessive growth of skin cells. Environmental, genetic, and immunologic factors appear to play a role. The disease most commonly manifests on the skin of the elbows, knees, scalp, lumbosacral areas, intergluteal clefts. The hallmark of psoriasis is sustained inflammation that leads to the uncontrolled keratinocyte proliferation and dysfunctional differentiation. It is said to be a multiple factorial disease, which means it's a combination of genetics and susceptibility factors. This means if one of your parents has it, you are more likely to have it. Also, it happens alongside other illnesses such as depression, type 2 diabetes, obesity, cardiovascular diseases, and metabolic syndrome. Next slide, please. So what causes psoriasis? So CD3 T cells and CD11C plus dendritic cells enter the skin. These cells are part of the immune system. These cause the release of inflammatory mediators. This activates keratinocytes. So in normal healthy skin, these make up most of the epidermis. They're produced by the basal layer, and throughout their life cycle of 21 days, they migrate to the surface and they lose their nucleus. However, in psoriasis, migration takes place in 3 to 5 days and they don't lose their nucleus, so thus they are immature and the skin is not properly developed. The inflammatory mediators also cause erythema, which is redness, and edema, which is swelling. So what are the symptoms of psoriasis? So the symptoms include red patches of skin covered with thick silvery scales, small scaling spots, dry cracked skin that may bleed or itch, itching, burning or soreness, thickened, pitted or ridged nails, and swollen and stiff joints.
Okay, to diagnose psoriasis, a GP will judge the condition of the patient's skin to see if there's any signs of the individual having the autoimmune disease. The doctors would then follow up with questions regarding your skin and will then examine your nails, skin, and scalp for further signs of the condition. There are also some cases where a small sample of the cells, known as a biopsy, which is a medical test where an extraction of sample cells is taken to determine a disease, would be transferred to a lab to undergo further examination to confirm whether the individual has psoriasis. Now, the biopsy is vital in order to ensure the type of psoriasis a patient can have. The biopsy can also be used to determine if the patient has a different skin disease, such as seborrheic dermatitis, which mainly affects the scalp and leads to the formation of itchy, flaky skin. But it can also be used to show whether a patient has a disease like Psoriasis rosea, which causes a temporary skin rash of raised red scaly patches on the body. If the doctor becomes uncertain with the diagnosis, a patient could be referred to a dermatologist where they would ask you to list your symptoms, for instance, irritative skin, and could ask if there is anyone in your family history who has psoriasis, or if there's been any drastic life changes which could lead to the increase in stress and development of psoriasis over time.
The epidermis.
Since psoriasis can most commonly be mistaken for eczema in the diagnosis process, it is important we notice the differences in the two conditions. Eczema causes an itch, which can cause skin to bleed. Psoriasis, on the other hand, is also known to cause itching. However, some patients also experience a burning sensation around sensitive areas. Eczema also appears red, flamed, and the texture of the skin tends to be quite leathery. Psoriasis can also cause red patches, along with the well-indicated silvery scales. The skin may appear much thicker and inflamed in comparison to eczema. Eczema can be triggered from irritable substances, such as detergents and soaps, but can also stem from allergies such as pets and pollen. Psoriasis shares common triggers to eczema, such as stress and infection, but it is also known to arise from triggers such as sunburn, vaccinations, and scratches, which can lead to skin becoming much more sensitive and prone to psoriasis.
So treatments are determined by the type and severity of your psoriasis and the area of skin affected. And your doctor will probably start with a mild treatment, such as topical creams applied to the skin, and then move on to stronger treatments if necessary. A wide range of treatments are available for psoriasis, but identifying the most effective one can often be difficult. And these treatments fall into 3 different categories: tropical, which are creams and ointments applied to your skin; phototherapy, so your skin is exposed to certain types of ultraviolet light; systemic, oral, and injected medications that will work through your entire body. And different types of treatments are often used in combination because it can be more effective. So treatments may need to be reviewed regularly. Patients might want to make a care plan, which is an agreement between them and their health professional, as it can help to manage their day-to-day health. And tropical treatments are usually the first treatments used for mild to moderate psoriasis. These are creams and ointments you will apply to affected areas. And some people find that tropical treatments are all they need to control their condition, although it may take up to 6 weeks to actually notice a noticeable effect. So if you have scalp psoriasis, a combination of shampoo and ointment may be recommended. Corticosteroids. These drugs are most frequently prescribed medications for treating mild to moderate psoriasis. They're available as ointments, creams, lotions, gels, foams, sprays, and shampoos. And mild ointments are recommended for sensitive areas, and tropical corticosteroids may be applied during flares. Emollients. Emollients are moisturizing treatments applied directly to the skin to reduce water loss and cover it with a protective film. And if you have mild psoriasis, an emollient is probably the first treatment your GP will suggest. And the main benefits is it will reduce itching and scaling. Steroid creams or ointments are also commonly used to treat mild or moderate psoriasis in most areas of the body. And the treatment works by reducing inflammation, which slows the production of skin cells and reduces itching. Vitamin D analogs are synthetic forms of vitamin D, such as calcipotriene and calcitriol, which slows the skin growth and can be used along with or instead of steroid creams for mild to moderate psoriasis, affecting areas such as limbs, the trunk, or your scalp. And they also have an anti-inflammatory effect. So calcineurin inhibitors such as tacrolimus and pimecrolimus are ointments or creams that reduce the activity of the immune system and help to reduce inflammation. They're sometimes used to treat psoriasis affecting sensitive areas such as the scalp, the genitals, and folds in the skin. And if steroid creams are not effective, these can be used, but can cause skin irritation or burning, itching sensation when started, but this should improve after a week. Coal tar is also used, which is a thick, heavy oil, and this reduces scaling, itching, and inflammation, and it might be used to treat psoriasis on the limbs, trunk, or scalp if other tropical treatments aren't effective. Dithranol, which is effective at suppressing the production of skin cells with few side effects, but it can burn if too concentrated. And next slide, please. So moving on to phototherapy. So phototherapy uses natural and artificial light to treat psoriasis, and artificial light therapy can be given in hospitals and some specialist centers, usually under the care of a dermatologist. So there are different types. UVB broadband, which controlled doses of UVB broadband light from an artificial light source can treat single patches, widespread psoriasis, and psoriasis that doesn't improve with tropical treatments. And short-term side effects may include redness, itching, and dry skin. But UVB narrowband light therapy is more effective than UVB broadband therapy and is usually taken 2 to 3 times a week until the skin improves, but it can cause more severe and longer lasting burns than UVB broadband therapy. Then there's Psoriasis plus ultraviolet A, which is also known as PUVA. And this treatment involves taking a light sensitizing medication before exposure to the UVA light. and UVA light penetrates deeper into the skin than UVB light does, and psoralen makes the skin more responsive to UVA exposure. PUVA is used for more severe cases of psoriasis, but it does have long-term side effects, such as wrinkles, dry skin, freckles, and even increased risks of skin cancer. Then there's excimer laser. With this form of light therapy, a strong UVB light targets only the affected areas of skin, and excimer laser therapy requires fewer sessions than does traditional phototherapy because more powerful UVB light is used here. Then there's also something called the Gokerman therapy, which is when doctors combine cold tar treatment, as I mentioned before, with light therapy, which is more effective because the cold tar makes skin more receptive to UVB light, therefore it'll work better. Then there's also retinoids, which are available as gel and cream and are often applied once or twice daily. Some examples are tazarotene and then there's also salicylic acid, and salicylic acid shampoos and scalp solutions reduce the scaling of scalp psoriasis, and it may be used alone or to enhance the ability of other medications to more easily penetrate the skin. Next slide, please. So moving on to tablets, capsules, and injections. So if you have moderate to severe psoriasis or other treatments haven't worked, your doctor may prescribe oral or injected systemic drugs. Because of the potential for severe side effects, some of these medications are used for only brief periods of time and might be alternated with other treatments. So there are two main types of systemic treatment. So there's non-biological, which is usually given as tablets or capsules, and then there's biological, which is usually given as injections. So I'm going to first talk about non-biological. So non-biological treatments include methotrexate, which can help control psoriasis by slowing down the production of skin cells, and it also suppresses inflammation. It's usually taken once a week, and side effects include nausea, and it may affect the production of blood cells, and long-term use can cause liver damage, which is why people who have liver disease or who are pregnant cannot take methotrexate, and you should not drink alcohol whilst taking it. Then there's cyclosporin, which is an immunosuppressant, and it's taken daily, but it can increase chances of kidney disease and high blood pressure. So along the treatment process, your doctor will be monitoring your blood pressure. Then there's acitretin, which is an oral retinoid that reduces skin cell production and is used to treat severe psoriasis that has not responded to other non-biological systemic treatments and usually taken daily. Side effects of this are dryness and cracking of the lips, dryness of nasal passages, and in rare cases, hepatitis. And then there are also some newer drugs, such as apremilast and dimethyl fumarate, which are newer medicines that help to reduce inflammation. And these are taken as daily tablets. However, these medicines are only recommended if you have severe psoriasis or if you haven't responded to other treatments, such as the biological treatments, which I'll be talking about now. So biological treatments, they reduce inflammation by targeting overactive cells in the immune system, and they're usually used if you have severe psoriasis or, like I said before, have not responded to other treatments, or if you cannot use other treatments. So the first one is etanercept, which is injected twice a week, and if there's no improvement in your psoriasis after 12 weeks, this treatment will be stopped. And the main side effect of this is just a rash where the injection is given. The second one is adalimumab, and it's injected once every 2 weeks, but if there's no improvement after 16 weeks, this treatment will be stopped. And the main side effects of this are headaches, a rash at the injection site, and nausea. Then there's infliximab, which is given as a drip infusion into your vein at the hospital. So you'll have 3 infusions in the first 6 weeks, then 1 infusion every 8 weeks. And again, if there's no improvement in your psoriasis after 10 weeks, this treatment will be stopped, and main side effects are headaches. And then there's ustekinumab, which is injected at the beginning of treatment, then again 4 weeks later. And after this, injections are every 12 weeks. And if there's no improvement in your psoriasis after 16 weeks, this treatment will be stopped. And the main side effects of this treatment are a throat infection, maybe, and a rash at the injection site. Now, it's important to keep in mind that since all of these treatments that I've just said here are biological treatments, these treatments affect the whole immune system, so there is a risk of serious side effects, including severe infections. Now, for newer drugs in biological treatments, there is an increasing number of newer biological treatments given as injections, which include guselkumab and brodalumab. Next slide, please. So now that I've finished up with treatments, moving on to alternative therapies. So alternative therapies claim to ease symptoms of psoriasis, and these can include special diets, creams, dietary supplements, and herbs. Some of these therapies might reduce itching and scaling in people with mild to moderate psoriasis. So for example, there's aloe extract cream, which may reduce redness, scaling, itching, and inflammation. There's fish oil supplements. Oral fish oil therapy used in combination with UVB therapy might reduce the amount of affected skin, and applying fish oil to the affected skin and covering it with a dressing 6 hours a day for 4 weeks might improve scaling. Then there's Oregon grape, which is a product when applied may reduce severity of psoriasis. And finally, essential oils, which can be used for aromatherapy, and this has been shown to reduce stress and anxiety because stress can be a trigger to psoriasis.
There are several complications caused by psoriasis which further compromise the health of the individual. So psoriasis can lead to an increase in the likelihood of developing eye diseases, as the same inflammation of skin cells in psoriasis can also impact the eye tissue. Eye diseases such as uveitis can occur whereby the middle surface of the eye, known as the uvea, can flare up. As the uvea consists of the iris, as shown in the diagram, this can affect a patient's ability to see clearly. Additionally, sufferers of psoriasis are at a higher risk of developing Parkinson's disease. This is because the neuronal tissue, which assists the body with movement and muscle contraction, can be damaged by the inflammation of skin cells caused by psoriasis. As a result of the detrimental damage on the neuronal tissue, the sufferer is at a higher chance of developing Parkinson's disease. Furthermore, another complication of psoriasis is that sufferers have double the risk of developing a cardiovascular disease, as psoriasis causes inflammation, and long-lasting inflammation in your body may affect your heart and cardiovascular system, compromising your health further. Next slide, please. An innovative idea that has evolved over recent years and is still under development is phototherapy. So phototherapy consists of exposing the skin to wavelengths of ultraviolet light, which penetrate the top layer of skin. And this prevents the skin cells from growing too quickly, as this is what ultimately causes psoriasis. As it prevents that from happening, it improves the symptoms experienced by the individual. Furthermore, scientists are also looking to develop creams such as gene-based gels, which aim to reduce the effects of psoriasis. Gene-based gels are being developed, for example, the AST005, which uses microscopic volumes of genetic material to inhibit the production of the TNF-alpha, which is a small protein used for cell signaling. And by inhibiting the production of the TNF-alpha, incorrect signals encouraging cell growth
plaques on the
would be
skin. They
made,
can be
and
embarrassing.
ultimately the
Afflicted
psoriasis would
reality TV
reduce.
star Kim
Next slide,
Kardashian
please.
and singer Cyndi Lauper have each spoken out about how psoriasis can have a significantly negative impact on the quality of life.
It's mainly believed that psoriasis most commonly affects males due to research which shows many men are concerned with treatment regarding psoriasis, and many men can be found in psoriasis registers. In Sweden, a study with 5,438 patients showed women had significantly lower incidence of psoriasis when compared to the data of the male patients. Throughout the years, psoriasis researchers even speculated that women have less severe psoriasis when compared to men. A survey released in recent years showed that psoriasis patients are not 100% satisfied with their treatment and would even report inadequate relief when facing symptoms such as scaling and itching. To further complicate the matter, experts stated that psoriasis is a real challenge to diagnose, as it can be mistaken for skin conditions such as pityriasis rosea and seborrheic dermatitis, as mentioned before. But it can commonly be misdiagnosed as eczema, which I have briefly gone through before as well. It is only after patients would report further spread of symptoms around sensitive areas of the body that the diagnosis can be narrowed down to psoriasis. There are also records of patients who may have tried topical treatments with limited success, and so would see further treatment as a waste of time.
Okay, thank you to group 2, and I'm going to pass it on to Nikki to quickly give us some feedback.
Okay. Yeah, well done, Hal's team, on going through psoriasis. Again, it's very well researched, and looking into the different types of treatment, which I can understand always be complicated, especially given your age when you haven't even started medicine. So this just goes to show that you guys are understanding and teaching others as well, really well. So well done. I know the theme of this session is autoimmune disease, and in essence, that's a bit like chronic disease as well. So, what do you think the life, as someone who has, just been diagnosed with psoriasis, how would you sort of explain to them what the disease or the condition entails, and what to expect in the future for them? Anybody can answer.
I would say that essentially psoriasis is when the body itself, it recognizes its own skin cells as foreign, and then what happens is the skin cells are just basically aging too quickly, and I would tell them that it can get more severe, like the severity will increase, but there are lots of new treatments that are evolving, such as the phototherapy. Ultimately, psoriasis isn't something that goes completely by itself, so I would recommend treatment. The creams would be good, but they're not as long lasting as the phototherapy. But I would also refer to their mental health, because I think that is something which isn't taken into consideration as much as an effect of psoriasis. Although obviously you've got like the scaly skin, it can also cause anxiety or depression, because some people may not want to go out looking differently to other people. So I just focus on all of the effects.
Yeah, and I think that's an excellent point as well, because this, this condition is affecting the person in general. We're not minimizing or diminishing the condition in itself, where there's scaly, more erythematous, which is more red, and plaque type skin, which can, the person can be visibly conscious about. And you're right in saying that it can hinder them from going out, meeting with friends, and just carrying on with their daily activities. And you said sometimes sun can trigger it, some various other different irritants that you sometimes can see in work can affect it. So they need to go through, again, some occupational therapy assessment for work, so it can affect their work. It can affect, like you said, their general health as well, because it starts affecting their eyes, their nails, their hair, their joints. So it's not just a skin condition, and it also is associated with other conditions like diabetes, cardiovascular diseases, like you said. So there's a lot involved with psoriasis, and it's not just a skin condition, which in the first few set of presentations, that's what the person might just be thinking about, and just might want to just have that sorted immediately and ask for a quick fix, which happens quite a lot. But it takes quite a lot of explanation and understanding, sitting down with the patient to try and just explain to them that this is a chronic disease, and sadly this will affect other body systems. But again, in that, to help them get the right kind of support and continue to support them throughout this disease progression is what's important. And this kind of awareness and just letting people know what psoriasis is about, and what it entails, and just sort of like helping the stigma around it would really be quite useful. I'm not sure if you guys have I don't know if anybody in school has psoriasis or anything, but especially in school, there are lots of kids who may have it. I know it comes at a later age, but any skin conditions that kids see, it's they're susceptible to bullying, which is what needs to be addressed. And this kind of awareness is sort of like a first step to it. So well done, and I hope everybody else has learned a little bit about psoriasis and what it entails as well. Well done, guys.
Thank you. And just quickly before group 2 finish, I'd just like to ask from the Slido, how exactly does UV light work as a treatment? So any of you can answer.
So essentially, the affected skin is exposed to like wavelengths of ultraviolet light, and they penetrate the top layer of the skin, and then that like prevents the skin cells from growing too quickly. I don't know if that explains it, but that's basically what the ultraviolet light does. And then because it stops it from growing too quickly, that ultimately is the main cause of psoriasis. So then they won't suffer from psoriasis.
Thank you for that. Now it's lunchtime, so feel free to have lunch. And one last thing to say is that thank you again to Ames Charity. Please make sure you donate to the through our link, which I'll put in the chat again. And we want to meet our goal of £35, so that would be very helpful if you could. And yeah, thank you. See you at 12:55. I shall share my screen now. All right, I think we're ready to start. I hope everyone has had a good lunch and they're ready for the last sessions of Mediccom. But before I introduce Dr. Eligar, I'd like to say again thank you for our first judge, which was Dr. Nikki, who was here previously. I completely forgot to thank her, so I'll pass on my regards to her. Next, I'd like to introduce Dr. Eligar if he'd want to talk about yourself for a little bit.
Sure. Thank you, Aryan. Thank you very much. It's great to see the whole group. It's well attended here. So I work as an endocrinologist at University Hospital of Wales. I've been there for almost 7 years now. So I have been through the training across in South Wales, most of my SPR training as well. So you guys are already doing a lot of good work. I don't have to tell you to get the scores or anything. I think what I can share with you as a medic and being in the medical field for more than 16, 17 years now is what you will find is you're already probably embodying a lot of these characters, but you'll have to extend that now to beyond your family and friends. And the main ones, what I feel when I'm working with a team is we can make out easily who is hardworking, honest, trusty, and who is empathetic towards the patients. These are simple characters, but this extend beyond the benefits. What it gives to the patients is beyond and unimaginable sometimes. And as a consultant endocrinologist, we deal with a lot of chronic diseases. So some of my patients are my most good friends as well now. Apart from being a patient, we have a lifelong association with them. So you spend some times, some of the most difficult times in their life, you are there with them, even more nearer than anybody else, because at that point in time, you are the one who is managing them. And some of these events can be life-changing for them in a positive way, and some may not be so life-changing. So in any case, they do remember you a lot. You are the one who's closest to them during the most difficult times and managing them throughout. So the character, what you build across, or when you move into your medical school, you will definitely imbibe all these things, almost like it's a contagion, mood contagion, like everybody in the system works in a similar way. So do what you're doing now. You're doing great. Be a good team member, flexible. You'll develop some negotiating skills as you go through, non-conflicting, resolving stuff by negotiation, and being helpful, and think beyond the box sometimes, and because that helps, and which you guys are already doing now. You're thinking beyond the box, especially with the Mediccom. Well done to you. So without talking too much about medicine or anything, I'd like to hear what you guys are presenting, and I will give my comments.
Thank you. I'll pass it on to Darshan to introduce the group 3.
Thank you, Dr. Eligar, for that. Now we have group 3 who are presenting about Guillain-Barre syndrome with speakers Chuka and Rowan. Good luck.
Thank you. Guillain-Barre syndrome by the Tumornators. And unfortunately, today, 2 of our team members, Harshita and Matthew, couldn't be here today with us.
Overview. What does this disease entail? Guillain-Barre syndrome is a rare disorder in which your body's immune system attacks your nerves. As a result of this, weakness, numbness, pain, and tingling in your extremities are usually the first symptoms. It mainly affects the feet, hands, and limbs. It can be treated, and most people will eventually make full recovery. However, although it can be occasionally life-threatening, and some people are left with long-term problems. Guillain-Barre syndrome affects people of all ages, but it is most common in adults and males. What type of condition is this? GBS is an acute paralytic polyneuropathy. Let's break this down. Acute shows that it is quick to affect the body. paralytic shows that it causes ascending and symmetrical peripheral neuropathy. This is all caused from damage to the patient's nerves. It is an autoimmune condition where your body is attacking your own peripheral nervous system. Damage to these nerves results in your muscles not working correctly, and so results in weakness and possibly even paralysis. It is usually caused by an infection such as cytomegalovirus, Campylobacter jejuni, or Epstein-Barr virus. It will end up affecting a patient's movement, sensation, and organ function. The first thing that we will talk about is the pathophysiology of the disease. This is the physiological process that is associated with the specific condition. It is crucial that we have a great understanding of our peripheral nervous system, PNS, as well as the anatomy of our nerves. The nerves in our PNS are located more around our muscles and outside of our central nervous system. The peripheral nervous system can be divided into two separate sections. The somatic section is responsible for the voluntary actions, where the autonomic section is responsible for the involuntary actions. When the autonomic section gets affected, the patient will lose functions in their body that happened automatically, such as breathing. This results in a severe case as the patient's organs will start to lose functionality. But the main question is, what results in this damage to the autonomic nervous system? This works by a process called molecular mimicry. A patient would have most likely experienced having some sort of infection or virus. B cells of the immune system create antibodies against the antigens on the virus, causing the infection. Unfortunately, these antibodies also match proteins on the nerve cells. This is what causes the body's own immune system to attack the nerves in the PNS and causes peripheral neuropathy. When we look at the anatomy of a neuron, we can specifically understand that the antibodies attack the proteins on the myelin sheath, which acts as an insulation to the axon, which is carrying an electrical pulse. It is this electrical pulse that gets ruined, destroying the nerve, meaning that certain actions cannot be carried out. The reason that the GBS has an ascending peripheral neuropathy is because the electrical signals have to travel the longest distance to reach the arms and legs, and so this is what will first be affected by the autoimmune disease. Here we have a timeline of a patient if they were to get GBS. In this case, the patient would have experienced a triggering disease such as gastroenteritis prior to developing GBS, and then after around 4 weeks, symptoms would start to appear. 2 to 4 weeks after this, the symptoms would peak. After this, it is simply a recovering period, which can range from months to years depending on the severity of the condition of the patient. It is now known that GBS can occur in several forms. The three main types are acute inflammatory demyelinating polyradicule neuropathy, AIDP, Miller-Fisher syndrome, MFS, and acute motor axonal neuropathy, AMAN. AIDP is most common in North America and Europe. This affects the peripheral nerves, and the most common sign is muscle weakness that starts in the lower part of your body and spreads upwards. This is ascending weakness and is generally symmetrical with a quick onset. When it affects the sensory nerves, the patient will have sensory neuropathy. In MFS, paralysis starts in the eyes. It is also associated with an unsteady gait. It can result in the patient being unable to speak or swallow. This form is most common in Asia. AMAN is more frequent in China, Japan, and Mexico. This is fairly similar to AIDP. How it differentiates itself, however, is that it has more axonal involvement in the nerve conduction. The condition is not passed from person to person and is not inherited either. The condition is caused by a problem in the immune system, where it mistakenly attacks the nerves. In most cases, it occurs a few days or weeks after a respiratory or digestive tract infection. Some of these infections include food poisoning, flu, HIV, cytomegalovirus, glandular fever, and also some tropical diseases such as Zika virus. Do vaccines cause an increased chance of having GBS? Interestingly, there have been reports where some patients who have received a vaccine may get GBS. This is because within the vaccine, the antibodies that get injected can target the nerves and cause GBS. It has been seen recently with the use of the coronavirus vaccines, where some patients have later been diagnosed with GBS. Fortunately, research has found that the chances of developing the condition after having a vaccination are extremely small, and so the benefits of having the flu vaccine or the coronavirus vaccine outweigh the small chances of getting GBS. A study into the vaccine using during the 2009 swine flu outbreak found that for every million people who had the vaccination, there were fewer than 2 extra cases of GBS. And evidence suggests that you are far more likely to get Guillain-Barre syndrome from an infection such as the flu than the vaccine designed to prevent the infection, such as the flu jab.
Diagnosis. GBS can be difficult to diagnose, but the physician will note that the symptoms appear on both sides of the body and that reflexes like the knee-jerk reflex are absent. The diagnosis of GBS is made clinically as there is no specific test that confirms a definitive diagnosis. However, there are some criteria called the Brighton criteria which can be used for a diagnosis. The Brighton criteria are used as a tool to assist in diagnosing GBS and help distinguish between low-risk and high-risk patients. They aid in the early and prompt diagnosis of the disease. The criteria also help in outlining the course of treatment required by the particular number of patients diagnosed with GBS. In an ill-equipped clinical setup, the Brighton criteria play a prime role in the detection of GBS. Furthermore, the diagnosis can be supported by investigations such as lumbar puncture to test for the CSF, where the CSF of someone with GBS will have higher than normal levels of protein, often greater than 0.55 grams per liter due to all of the inflammation. And white blood cells will be less than 10 per cubic millimeter of CSF. These two CSF findings are important to distinguish GBS from lymphoma and poliomyelitis, which both reveal elevated protein and elevated white blood cells in the CSF. Nerve conduction studies, which show reduced signal throughout the nerves, and electromyography are not required for diagnosis, but help distinguish from other causes of acute muscle weakness. Nerve conduction velocity can be measured by placing electrodes on the skin at different locations. The electrode stimulates the nerve, and the other electrode picks up the electrical activity in the nerve. The distance between the electrodes and time to transmit the impulse between the electrodes can be measured. With GBS, conduction times are usually slower. Electromyography tests the response of a muscle in response to a nerve stimulation of that muscle. In the acute phase of GBS, EMG studies often show decreased recruitment of muscles. Symptoms. How is GBS recognized? GBS is characterized by a relatively sudden, unexpected onset of symptoms. They usually develop over the course of about 3 weeks, but can develop as rapidly as days or hours. Some of the early symptoms include numbness, pins and needles, muscle weakness, and sometimes even paralysis. This usually begins in the legs, but may then spread to the arms and upper body. The sensations are ascending, meaning that they start in the extremities and travel up the limbs towards the torso. People may also experience pain and problems with balance and coordination. The symptoms may continue to get worse over the next few days and weeks. Later symptoms include difficulty walking without assistance, difficulty breathing, blurred or double vision, difficulty speaking or swallowing, and finally, difficulty with digestion. There is a wide range of symptom severity, from mild cases with brief weakness that may not even be enough for the person to seek medical care, to life-threatening paralysis with an inability to swallow and use breathing muscles. It depends on which particular nerves are affected by the demyelination. Guillain-Barre syndrome usually reaches its most severe point within 4 weeks. It then remains stable for a few weeks or months before gradually improving.
Current treatment. The majority of patients diagnosed with Guillain-Barre syndrome will be treated and cared for in hospital for at least a few weeks, but can be there for months. Usually the effects of GBS will peak around 4 weeks after the symptoms have started, and it is essential that the doctors monitor the patient during this time, as GBS causes ascending paralysis, and so the severity of the disease in the patient can rapidly increase. The main treatment involves reducing the effects of the symptoms and shortening the recovery time, as unfortunately there is no direct cure for GBS. For the majority of the time, plasmapheresis, also known as plasma exchange, is used to treat patients, where treatment is needed for around 5 days. Instead of injecting donated blood into the patient's vein, as in IVIG, the patient's own blood is taken from their vein, so that the harmful antibodies that were attacking the patient's nerves, more specifically the myelin sheath, can be filtered out. The filtered blood is then injected back into the patient's vein. Otherwise, Guillain-Barre syndrome can also be treated by using intravenous immunoglobulin, also known as IVIG. IVIG is the use of healthy antibodies in donated blood. This is directly injected into the patient's vein. These healthy antibodies halt the harmful antibodies that are attacking the peripheral nervous system. Venous thromboembolism, VTE, is a formation of blood clots within the veins in the legs. This can be treated with the use of prophylaxis, such as heparin, which will prevent the blood clots. Most importantly, this will then take out the risk of the blood clots moving towards the heart, causing pulmonary embolism. In severe cases, the autonomic nervous system will be affected. Therefore, there can be cardiac arrhythmias and blood pressure instability, which needs to be monitored carefully by the nurses. In the case that the patient develops difficulty breathing, the doctor may give the patient a ventilator and intubation, or even an admission to the intensive care unit. This would be due to a paralyzed diaphragm, which is caused by the ascending paralysis. A patient may also experience diaphagia, also known as swallowing problems, where the doctor would give the patient a feeding tube to help the patient digest food. Again, this would be a result of ascending paralysis. To reduce the patient's pain in the muscles due to the antibodies attacking the patient's nerves, the doctors can prescribe the patient painkillers. The doctors may ask the patient to patiently walk around their bed and wards so that the patient's joints do not get too stiff. If a patient has difficulty excreting the urine, the doctors may have to insert a catheter, which is a tube that is inserted into the patient's urethra and allows the urine to be safely excreted. The patient may experience constipation, where the doctors will give the patient laxatives. The doctors may give the patient special leg stockings if the patient has blood clots. Doctors will avoid any use of steroids to treat GBS, as there has been no evidence to show that using steroids has any benefits on affecting GBS.
Most people with Guillain-Barre syndrome recover completely or have only minor residual weakness, numbness, or tingling. However, there are 6 main complications that may occur as a result of contracting this syndrome. Guillain-Barre syndrome affects your nerves, and since these are responsible for your movements and body functions, any complications that arise are to do with this. The first is breathing difficulties. Sometimes the paralysis or weakness can spread to your breathing muscles, such as your intercostal muscles and your diaphragm. This is potentially fatal, and up to 22% of people need breathing equipment within the first week of being hospitalized. The second is nerve pain, which can be very severe, and certain medications are used to ease it. The third complication is heart and blood pressure problems. Pressure fluctuations and irregular heart rhythms, also known as cardiac arrhythmias, are common side effects of Guillain-Barre syndrome. The fourth possible complication is blood clots. This is because Guillain-Barre syndrome can sometimes leave you immobile, and this can lead to blood clots. To treat this, blood thinners could be taken, as well as wearing support stockings. Sluggish bowel function and urine retention is another complication. But the final complication is pressure sores, which also happen from being immobile. However, frequent repositing can also prevent this. Unfortunately, 2% to 5% of people with Guillain-Barre syndrome experience a relapse. Rarely, death may occur from complications such as respiratory distress syndrome, heart attacks, blood infection, lung clots, and cardiac arrest. Ethical concerns. Here is a quick recap of the 4 pillars, and as they are shown in the slides, the 4 pillars are autonomy, meaning patients have free choice and ultimate decision-making ability; justice, where all treatment should be in compliance with the law and the patient's rights; beneficence, all doctors have the moral duty to provide treatment which is in the best interest of their patients; non-maleficence, doctors are obligated to do no harm when treating their patients. This is the first of the 2 scenarios we came up with, and it surrounds a patient who has developed acute GBS. The disease can have extremely life-altering effects, such as paralysis of major areas of the body. In this instance, if the paralysis somehow impedes the patient's speech or communication with the doctor, then it may not be possible for the patient to carry out their own decisions regarding their treatment. This would mean that someone other than the patient would be making their medical decisions. And while this could be seen as the patient losing autonomy, as there is no other way for the patient to communicate, in this instance, it would obviously not be objected to. However, more pressure may then fall on the medical practitioner in ensuring that the treatment that the patient will receive is completely in their best interest. The second possible ethical concern is to do with the treatment of GBS. Some of the treatments involve blood transfusions, and this can be an ethical concern for certain groups. Some religious people, such as Jehovah's Witnesses, for example, do not accept blood transfusions, and this could potentially add difficulties and complications when trying to treat them using IVIG. However, as the patient has autonomy, they have the right to refuse it. Then alternatively, the treatment of plasma exchange involving the patient's own blood could then be used.
Analytic. The condition is very rare and only 1 in 100,000 people will actually have it. Some extra facts are that about 20% of patients with GBS develop respiratory failure. GBS incidence increased by 20% for every 10-year increase in age. The risk of GBS is higher for males than females. Around 1 in 20 cases are fatal. GBS reoccurs in 1 to 6% of patients. 40% of cases are caused by Campylobacter jejuni. 80% of patients will recover from the condition, and 15% will get left with some neurological disability.
Here are some of the links that we used when researching for the disease. Thank you for listening.
That was a brilliant presentation, Rohan and Chuka. I think it was amazing to listen to the clarity with which you spoke and bringing the whole GB syndrome picture in a nutshell, in a very, very organized way. Well done, guys. I was told that I can ask you a question, but I'm struggling to ask you a question because you covered everything. So instead of asking a question, I'll just add a few things. You said about intubation. Intubation, always they go to ITU. You did mention that, but that's one of the things is when they get intubated for respiratory support, they have to be in ITU. And the MFS variant, what you mentioned, the Miller-Fisher variant, basically you mentioned that the GB syndrome starts from the lower down, like legs, and starts and goes up. That's the common presentation. There's another presentation which you mentioned, the MFS, which affects the eyes basically. The first thing what you notice is they're not able to focus, and if you examine their eyes, they have a kind of what we call as nystagmus, which is not very commonly seen, and the conjugate movements of the eyes are affected. So it's not so common, but it can happen everywhere across the world. I'm not sure if it is focused only for Asian geographical areas. But apart from that, I think it's mind-blowing how you guys are able to do such an excellent presentation with very minimal background medical knowledge. And hats off to you. Well done. Well done. I'm quite impressed.
Thank you.
Thank you.
Ready for the next one, Aryan?
Thank you, Dr. Eligar. So now we're going to hand over to group 4, who will be presenting about celiac disease. So good luck.
I'm sorry, but can I wait for my team member, because I don't think she is online at the moment.
Yeah, no problem. How long do you think she'll be? 5 minutes?
Not sure, maybe 5 minutes. I'll call it. Oh, all right.
I am here.
Sorry, I thought you weren't there.
Yeah, feel free to share your, can you hear me? Feel free to share your presentation and start whenever you feel.
Good afternoon, everyone. My name is Kare.
Okay, I'm ready.
Okay, great. The slide's not presenting.
Is it?
No, it's not.
Hang on. Oh, I don't have enough memory. It says.
Okay, I'll try doing it. Don't worry.
Actually, yeah, I think I can do it. Never mind. Kia?
Yeah. Are you doing it, or shall I?
Yeah, I'm doing it. I think it's fine at the moment.
We can't see your slides right now. We can only see.
No, okay.
No, we can only see your Google Slides right now.
Present it then. Can you present it then?
Okay, yeah, sure. Okay. Good afternoon, everyone. My name is Kare.
And my name is Diana. Today we're going to talk about celiac disease.
We also had a third member, Ella. She did the research, but unfortunately she couldn't come today. So we're going to say her part too.
So first of all, let's start with some general introduction.
Celiac disease is a condition where your immune system attacks your own tissues when you eat gluten. This damages your gut, so you're not able to take in nutrients. Next slide, please. There are a few types of CD which have got an iceberg model as shown at the right in the diagram. Firstly, for symptomatic CD, the patient usually experiences the common CD symptoms, as well as presenting villus atrophy, which is the shortened and burned villi. In silent CD, however, the patient often shows villus atrophy only, with the absence of any symptoms, while latent CD is proposed for those subjects who show neither the symptoms nor villus atrophy, and yet have immunological abnormalities similar to those found in celiac patients. Now, apart from those three forms of CD, we also have something called refractory celiac disease, also known as RCD. It is much like the common celiac disease, but the patients would experience recurrent malabsorptive symptoms and villus atrophy, despite the fact that they've had at least 12 months of treatment with strict gluten-free diet. RCD type 1 patients has a normal intraepithelial lymphocyte phenotypes, whereas RCD type 2 patients express abnormal intraepithelial lymphocyte phenotype, which is more than 50% or 20 to 25% IEL with abnormal lymphocyte phenotype like CD3 to CD8. Next, let's look at the pathology. When gluten enters the small intestine, part of it is broken down as gliadin. It is believed that people with genetic susceptibility to develop CD, gliadin interact with the intestinal cells to trigger the disassembling of the interenterocyte tight junctions, which is the TJS. The impairment of the TJS determines the upregulation of zonulin, peptide responsible for the increased gut permeability. Gliadin peptides can therefore pass through the epithelial barrier and can be picked up by the APC in the lamina propria. The gliadin is converted to deaminated gliadin peptide through tissue transglutaminase, which is known as TG. The deanimated gliadin peptide can also be picked up by the antigen-presenting cells, but more efficiently, and it is presented on the HLA-DQ2 or HLA-DQ8 receptors. This causes the monocytes to produce interleukin-15, which is a cytokine that stimulates CD8 T cells and natural killer cells activation, proliferation, and cytolytic activity. TG autoantibodies are proposed to occur by APC inadvertently take up TG gliadin complexes, resulting in the production of TG antibodies against both gliadin and TG. It has been proposed that TG autoantibodies plays a role in disease pathogenesis, but lacks sufficient supportive evidence. The ATC then activates CD4 and CD8 T cells. The CD4 and CD8 cells will lose their L section and CCR7 receptors, which will prevent them from leaving the Preyer's patches or leaving the lamina propria. A new receptor called the homing receptor start to present, which will guide the lymphocytes to the designated area through lymph vessels and that kind of stuff. The CD4 cells also activate a naive B cell, which start to express IgA antibodies, which is achieved by Th2 cells secreting interleukin-5 and interleukin-6. The lymphocytes then travels to the mesenteric lymph nodes, where the naive T cells that refers to the CD4 and CD8 T cells there, are activated, as well as the naive B cells. Next, all these activated lymphocytes then travel to the designated area. There, the naive B cells become mature IgA presenting plasma cells producing anti-Gliadin, anti-endomycin, and anti-ETG antibodies. CD4 cells become T helper cells, whereas CD8 cells transfer to T killer cells and memory cells. These IgA antibodies prevent infection by neutralizing the antigen and bringing it to the lumen, where it is egested. In addition, gliding peptides upregulate the MICA on the enterocytes and the NKG2D receptor on the CD8, infiltrating intraepithelial lymphocytes. This will result in the CD8 infiltrating intraepithelial lymphocytes producing cytotoxins, working along with the natural killer cells, and this leads to villus atrophy. The T helper cells would release cytokines, which leads to the inflammation of the small intestine. As a multifactorial disease, currently we have not found a definitive cause of CD, but there are a number of factors, both genetic and environmental. Genetic-wise, one of the main factors is the presence of HLA genotypes. It is found that 90% of the patients expressed HLA-DQ2, while the rest expressed HLA-DQ8. Both HLA-DQ2 and HLA-DQ8 are MHC class 2 proteins. However, the frequency of a CD risk HLA genotype is about 30%, while only 1 to 3% develop CD. Therefore, we can see that HLA genotypes are not sufficient enough to become the onset factor of CD. Recent research has also found 39 other non-HLA genes that have been linked to CD. Among those genes, the gene MYO9B, when showing homozygosity with HLA-DQ2, is suspected to be involved in the progenesis of CD and the chance of developing RCD2. Moving forward to the environmental factors. The timing of introducing gluten at infancy and breastfeeding pattern is one of them. A recent 10-year observational study, the DAISY study, showed that the children exposed to gluten during 4 to 6 months had lower risk of developing CD than those exposed to gluten in the first 3 months, which is 5 times lower, and those exposed at 7 months and after, which is slightly lower. However, the study did not include data on the amount of gluten ingested by the babies at different months. Another study has also found a negative correlation between the duration of breastfeeding and the development of CD, where the babies are breastfed during the introduction of glutens had 52% lower risk of developing CD compared with those who were not breastfed when gluten is introduced. Lastly, research has also linked frequent rotavirus infection at childhood to a higher risk of CD compared with those with zero infections.
Diagnosis. So the first stage of testing for celiac disease involves a blood test that looks for celiac antibodies, the LGA. This test can usually be performed in your local GP surgery. It is suggested that patients show LGA deficiency are also referred to TCGA, so this is a tissue transglutaminase antibody test, and or deaminated gliadin peptide LG test, which is more recent and 10 to 15 times more common in patients with CD. celiac disease. The doctor may also look for the presence of HLA-DQ2 or HLA-DQ8 and any other family history of the patient with celiac disease. If your blood test is positive, you will be referred to a gastroenterologist at your local hospital who will perform an endoscopy, which allows the doctor to examine your small bowel. During the endoscopy, a small sample of cells from your gut will be taken for closer examination. This is called a small bowel biopsy. If your endoscopy and biopsy show signs of the type of gut damage associated with celiac disease, you'll be given a formal diagnosis of the condition. However, due to the COVID-19 pandemic, a change to the guidance for diagnosis means that for some adults with very high antibody levels, a diagnosis can be made with a further blood test and without need for a biopsy. So refractory celiac disease is a rarer type of celiac disease where the symptoms continue even after switching to a gluten-free diet. The reasons for this right now are unclear. It's estimated that around 1 in every 140 people with celiac disease will develop the refractory form of the condition. If refractory celiac disease is suspected, it's likely you'll be referred for a series of tests to make sure your symptoms are not being caused by another condition. If no other cause can be found and the diagnosis is confirmed, you'll be referred to a specialist. Treatment options include steroid medication such as corticosteroids or prednisolone, which can help block the harmful effects of the immune system. Okay, now we move on to the complications. In celiac disease, the immune system attacks the lining of the small intestine, which reduces the ability of the intestine to absorb the nutrients. So children and adults with untreated celiac disease may become malnourished because they do not get enough nutrients, resulting in anemia, weight loss. Also with children, this can lead to delayed growth or small stature. Among the possible complications of untreated celiac disease, the main one is the inability to develop the optimal bone mass in children and the loss of bone in adults, both of which increase the risk of osteoporosis. Osteoporosis is a condition in which the bones become less dense and this means they are more likely to fracture, and fractures from osteoporosis can result in pain and disability. Osteoporosis can be also treated by taking medication to strengthen bones and prevent bones from breaking. Another important mineral is iron, which has many functions in the body, most notably creating and maintaining a number of red blood cells which transport oxygen around the body. Iron deficiency is common in people with undiagnosed celiac disease because the body isn't able to absorb iron from food very well. This is because the damage to the gut lining caused due to the damage caused by eating gluten. Iron is an essential part of hemoglobin and the red pigment in blood, which is needed to transport oxygen around the body, as mentioned before. Iron deficiency occurs when the body's iron stores are low. It's diagnosed by a small, simple blood test, which measures your blood hemoglobin levels. An interesting fact is that a quarter of adults are actually estimated to be anemic due to iron deficiency upon diagnosis with celiac disease. There are also iron and folate deficiencies. So these are more common causes for anemia in people with celiac disease because these nutrients are absorbed in the two upper parts of the intestine where damage occurs in the earlier stages of celiac disease. So when the disease progresses, the lower part of the small intestine can be damaged and cause vitamin B12 deficiency. So shortage of this can lead to anemia, as mentioned before, and also this vitamin is also very, very essential for the growth of red blood cells, therefore consequently leading to anemia. There are also other complications such as infertility in women and lymphoma. So this is cancer of the lymphatic system, which is part of the body's germ-fighting network. The treatments. So when you're first diagnosed with celiac disease, you'll be referred to a dietitian to help you to adjust to your new diet without gluten. A dietitian can also ensure your diet is balanced and contains all the nutrients you need. If you have celiac disease, you'll no longer be able to eat the food that contains barley, rye, or wheat, including farina, graham flour, semolina, durum, and cowshes and spelt. Even if you can only consume small amounts of gluten, you may also have an unpleasant intestinal systems. If you keep consuming gluten regularly, you'll also be at a greater risk of developing osteoporosis and cancer in later life, as I mentioned before. Gluten is not essential to your diet and can be replaced by many other foods. Many gluten-free alternatives are widely available in supermarkets, including pasta, pizza bases, and bread. Some GPs may also provide gluten-free foods on prescription. There's foods such as meat, vegetables, cheese, potato, and rice, and these are free from gluten, so you can include them in your diet. Also, a dietitian can help you with further help. Another treatment would be vaccinations. In some people, celiac disease can cause the spleen to work less effectively, making you more vulnerable to infection. You may therefore need to have extra vaccinations, including influenza, HIV, Men C vaccine, which protects against sepsis, pneumonia, and meningitis. So this is the infection of the lining in your brain. And pneumococcal vaccine, which protects against infections caused by the Streptococcus pneumonia bacterium. However, if your spleen is unaffected by celiac disease, these vaccines are unnecessary, and another treatment can supplement this. As well as cutting gluten out of your diet, your GP or dietitian may also recommend you to take vitamins and mineral supplements, at least for the first 6 months after your diagnosis. This will ensure that you get all the nutrients you need while your digestive system repairs itself. Taking supplements can also help correct any deficiencies such as anemia.
On to the further treatment. As I explained earlier in the pathophysiology, zonulin is responsible for the increase in permeability of the small intestine, which might result in gliadin entering the Prae's patches and triggering the immune response. Therefore, I looked into larazoltide acetate, or also called larazoltide, which is a zonulin inhibitor that could potentially re-regulate the TGS and prevent the gliadin from entering the Prae's patches, and thus prevent the immune response during gliadin ingestion of a patient. In vitro, which is in laboratories, it is proven that it prevents the opening of the TJS. In vivo, which is clinical trials, the results from 3 double-blinded placebo-controlled randomized clinical trials on CD patients with gluten challenge, 2 has shown that there were no difference in increase in the LAMA ratio in the larazoltide group compared with the placebo group. 1 reported that the increase in LAMA ratio associated with the gluten challenge was not statistically significantly greater than the increase in the gluten-free control group. This suggests that the drug does not alter or improve the ratio between the intestinal permeability and the small intestine absorption capacity in those patients. However, one of the research found that at lower dose, mean ratio of anti-tissue transglutaminase and IgA level was lower than the larazoltide group at lower dose compared to the placebo group. This indicates the possibility of this drug in limiting the gluten-induced immune reactivity and symptoms in patients with CD in gluten challenge. 2 of the studies has also showed that larazoltide appeared to limit gluten-induced worsening of gastrointestinal symptom severity as measured by the gastrointestinal symptom rating scale at some lower doses. Lastly, out of 3 trials, for the adverse event, 1 suggests that it is common to have headache and urinary tract infection, whereas the other 2 found that there were no significant difference between the adverse event rate between the larazoltide group and the placebo group. In conclusion, Larazotide is an effective chemical on reducing gluten-induced immune reactivity and symptoms at lower dose among patients taking gluten challenge. However, more investigation is required on this chemical.
So the ethical concerns. So ethics and ethical concerns are a major part of medicine, and they come into many different diseases, treatments, everything, medicine. So these also exist for celiac disease. So screening for celiac disease is a controversial argument. So screening is the act of doing a test on a person or a person's blood or urine, etc., to look for evidence for the disease. It is one of the most common lifelong disorders, affecting 0.5 to 1% of the population. Many of those affected are not diagnosed because of the wide spectrum of clinical presentations. People who remain undiagnosed are at a risk of long-term complications, including infertility, osteoporosis, and lymphoma. These prompt diagnosis is important not only to enable appropriate treatment of symptoms, but to prevent future complications. Since diagnosis takes 7 to 10 years, arguably surgical screening will increase the quality of life for many people. And this is a massive ethical argument about celiac disease right now. So screening also coincides with the NHS core principle to focus on the well-being of the patients. It also coincides with the medical ethic of beneficence. Furthermore, increased awareness of the disease coupled with a low threshold of serological testing for antibodies will undoubtedly uncover a large portion of these with those with undiagnosed disease. On the other hand, there is an argument that disagrees with this. Due to the 4 pillars of medical ethics, which are autonomy, beneficence, non-maleficence, and justice, a competent patient has a right to make their own decision on their treatment, care, and this is the ethics of autonomy. The NHS has a restrictive amount of money to spend on each department, and this is the whole concept of CCG. So these are clinical commissioning groups, and they are given an annual budget to cover the majority of the NHS spending, and they allocate a certain amount of money to each department. And the NHS has restricted money to spend on each department, and if they increase expenditure in a certain department, it would not increase massively. Therefore, the argument comes to what remains to be established by cost-effective analysis is whether we should adopt mass screening of the general population or focus our resources on people who are at risk of celiac disease, such as patients with symptoms, as mentioned before, or other conditions associated with diseases. So these are type 1 diabetes or Hashimoto's disease, Down syndrome, and people who are at risk of having the disease, for example, relatives of someone who has celiac disease. So my opinion on this debate is to screen for celiac disease if the patient shows any sign of the symptoms, like severe or occasional diarrhea, and other symptoms include excessive wind or constipation, persistence or unexplained nausea and vomiting, recurrent stomach pain, cramping or bloating, any combination of iron, vitamin B12 or folic deficiency, anemia and tiredness. So this will respect, if we look for the symptoms and then screen, this will respect the patient's autonomy because it's not making it compulsory, but it will also benefit the patient because it's helping them overcome their illness, and it will also help the NHS to save money and spend it where they really need it. Thank you for listening.
And please feel free to ask any questions.
Okay, that was again another brilliant presentation, Tina and Kea. So I thought that the way you have understood the complex pathophysiology of celiac disease, even to a trained medic, it is quite not so easy to grasp all the all the aspects unless they are day in and out trying to do the thing. It's a very good work. I can see the hard work that you guys have put into learning this topic and the passion to learn and present it. Very good, well presented. One thing was about the immunoglobulin A. I think sometimes you thought it was LGA. Actually, it's and at once I think you did mention that it's IgA. It's immunoglobulin A, IgA. And I like that last debate, what you mentioned, Kea, about who should we screen. The targeted population screening is what we usually tend to do. And that's right, absolutely straight on. That's where we spend the money, and you get the most for spending the money is on the targeted population. And you picked up on two things: type 1 diabetes and Hashimoto's disease. Why do you think we should, one question, if you don't mind me asking you, why should we screen in these patients?
Can I answer this one?
Yeah, go ahead, Diana.
Because I come across in some papers that has said, because celiac disease patients, they have problem with their HRA, DQ2 and DQ8 component of the receptor. And I've came across, they say diabetes patient has also got this kind of problem with their receptor. So anyone with the HRA genotype are likely to develop CD and diabetes and Hashimoto disease.
Very good, well done. So basically, if you see that your topic was celiac disease as an autoimmune condition, so type 1 diabetes is an autoimmune condition. Hashimoto's disease, which is the hypothyroidism, is an autoimmune condition. So all these three conditions can coexist in the same person. They may not all happen at the same point in time, but they may come across, uncover themselves during their lifetime at different points in life. So as a part of targeted screening, we do screen for thyroid dysfunction and celiac disease in type 1 patients. And in Hashimoto's disease, which is a very common form of hypothyroidism, we treat them with a medication called thyroxine. It's a very simple treatment, and patients are mostly well. But patients who have celiac don't observe this thyroxine. So how much ever you give them the medications, they still feel the symptoms, and the blood tests will show that, oh, they're still under control or not very well controlled. And this is when our targeted screening comes through. And first thing we do is check for anti-TTG antibodies or anti-tissue transglutaminase, which you mentioned. So that's the reasoning why we do the targeted screening. Well done to both of you. No more questions. I think you guys are doing great. Keep up the work. I'm glad that I'm listening to this. Thanks for the organizers. I'm really enjoying it. Thank you.
Thank you.
Thank you.
Welcome.
Just before we go into the next group, there's one question.
Yeah.
For the speakers, or you can take over.
Yeah, no, the speakers are the experts now.
The question is how different is the treatment for celiac disease in children as opposed to adults?
Okay, I'll go. The treatment is no different. It's the same. So celiac is quite often recognized even in children. So the treatment will not be anything different because the pathophysiology is same. What's going on is the same. So if you see in most of the supermarkets, there is always an aisle for gluten-free food. So next time you go through, that means there is so much of population around there with celiac. So even at the level of at marketing levels, there is investment into gluten-free diet.
Thank you for that answer. That was detailed enough for anyone to understand. Now I'd like to pass it on to Ayat to introduce the next group.
Okay.
Yeah, so for the next group is Autoimmune Vasculitis by Maisha, Katrin, Shada, and Minna. So yeah, could you share your screen, please? Thank you. Or could you also turn your cameras on? That would be really great.
Okay. Can you hear me? And am I on mute?
We can hear you.
Okay. Okay. So firstly, what is autoimmune vasculitis? Autoimmune diseases are related to or resulting from an immune response by the body against antigens in its own cells or tissues. Vasculitis is the inflammation of blood vessels. So in other words, autoimmune vasculitis is when immune system confuses a part of its normal body as a foreign invader, and that there are a couple ways that this might happen, and I will cover it later on. Vasculitis classically refers to arteries rather than veins because usually they are the ones affected. Vasculitis can be primary or secondary. Primary vasculitis is its own disease, and secondary vasculitis can being secondary to drug, another disease, or malignancy. Primary vasculitis is classified into the size of the blood vessels affected. There are large blood vessel vasculitis, such as those diseases that are affected by the aorta and its main branches, the medium vasculitis, which are those affecting the branches by the kidneys, and the small vessel vasculitis, which is affected by the atrials and the capillaries. Sometimes the body confuses the innermost layer of the blood vessels, which it's the endothelial layer, with a foreign pathogen and directly attacks it. To be more specific, the white blood cells of the immune system mixes up the normal antigens and the endothelial cells with the antigen of the foreign invaders, such as the bacteria, simply because they look similar. This is called molecular mimicry. This autoimmune confusion is thought to be the cause of several types of medium and large vessel vasculitis. For small vessel vasculitis, the immune system attacks the healthy cells that are near the vascular endothelium, and the endothelial cells are only indirectly damaged. Once the endothelium cells are damaged, directly or indirectly, almost all vasculitis diseases progress in a similar way. The damaged endothelial exposes the underlayer collagen of the tissue, and these exposed materials increase the chance of blood coagulation. The blood vessel walls become weaker and allow aneurysms to become more likely. And finally, the vessel walls heal. It becomes harder and stiffer because the fibrin is deposited into the vessel walls in order for it to heal.
A series of blood tests are taken in order to diagnose a person with autoimmune disease. This is to check for signs of inflammation. Doctors can also count the number of blood cells. This will see if there's enough red blood cells that are sufficient for everyday life. Another form of diagnosis is imaging tests. It can monitor whether you are responding to treatment and decipher if you have this condition. Tests include X-rays, ultrasound, computerized tomography, MRI, PET. It is important to carry out multiple different diagnoses because it is crucial to rule out any other illnesses that mimic the effects of this condition. Angiography can take place during this method. A catheter is inserted into a large blood vessel. A dye is injected through the catheter, and X-rays are produced as the dye fills the blood vessel. The final diagnosis procedure is biopsy, where the medical expert removes a small sample of tissue from the affected area. This is then examined for signs of the disease.
Unfortunately, there is no actual cure for vasculitis yet. However, there are many medications that can be used to help reduce the damage created by vasculitis and reduce its symptoms so the patient can lead as close to a normal life as possible. The treatment consists of medical treatment and may involve surgical procedures. The medical treatment consists of getting the disease under control by using high doses. This is called the remission induction phase. Once achieved, doctors have to try to keep the disease under control. This is done by reducing the dose of the steroid and may replace the toxic drug with a less toxic one. This is known as a remission maintenance phase. There are different medications used and almost all aim to reduce the autoimmune response and the damage to the end organ, which is the organ that was last affected. These include corticosteroids, for example prednisone, monoclonal antibodies, for example rituximab, alkylating agents, for example cyclophosphamide, and antimetabolite immunosuppressants, for example methotrexate and azathiopurine. The medication prescribed will vary on the type of vasculitis, the severity of the organ affected, and the certain clinical conditions. Prednisone is a corticosteroid. It prevents substances in the body that can cause inflammation to be released. They are the most common drug for vasculitis as they have very broad effects on the inflammation and are rapidly acting, which hopefully results in a less severe vasculitis. This makes them more viable for the treatment. What can you expect the treatment to be like? Prednisone is given via the mouth or by injection into the vein. The doctor will prescribe the appropriate dosage of medicine depending on how severe the vasculitis is and which organ is affected. In most cases, when starting the vasculitis treatment with prednisone, the dose is high. This is then reduced depending on how well the vasculitis reacts to this treatment. Usually, the doctors will ask their patient to take prednisone once in the morning as it acts like a hormone cortisol, which your body secretes during that time of day. Cortisol increases sugar in the bloodstream. It enhances your brain's use of glucose and increases the availability of substances that repair tissues. It also controls functions that would be non-essential or harmful in fight or flight situations. Rituximab is usually prescribed to treat rheumatoid arthritis patients. It's a monoclonal antibody, so it works by attaching to B cells and lowers a number of them to reduce the inflammation. Rituximab is used due to the B cells targeting their antibodies to granules made by the neutrophils, so the immune system starts attacking itself. The B cell releases an antibody which binds to the neutrophil, which then releases oxygen-free radicals, which damage the endothelial cell. It has been approved to help with the treatment of granulomatosis with polyangiitis, which mainly affects the ears, nose, sinuses, kidneys, and lungs, and microscopic polyangiitis, which can affect the kidney and nervous system, skin and lungs. So the treatment detail, the rituximab is given intravenously. This can be done in an infusion center or hospital. The treatment time takes 4 to 6 hours or longer. The dose and frequency of the rituximab will also be determined by doctors based on how severe the vasculitis is and many other factors. Cyclophosphamide is a powerful medication. It's classified as an alkylating agent which prevents cell division by damaging its DNA and reduces the activity of the immune system, therefore reducing the damage caused by vasculitis due to it suppressing the immune system. This is useful because vasculitis is caused by an overly active immune system, and by suppressing it you are decreasing the activity of it. It's advised to avoid pregnancy and contraception during and 3 months after treatment for men and women. Cyclophosphamide is taken orally or intravenously. When taken orally, the typical dose is 1 to 2 milligrams per kilogram of body weight, which should be taken in the morning. It's advised to drink lots of water throughout the day. This will help to flush the medication out of the body in the urine. If a doctor administers the drug intravenously, they will determine the dosage based on the height, weight, and kidney function levels of the patient. Methotrexate is an immunosuppressant. It slows down your body's immune system and reduces the strength of the immune system's attack on the cells to help reduce the vasculitis. It also helps reduce inflammation. It's used to treat rheumatoid arthritis. Methotrexate is taken once a week. It comes in 2.5 milligram tablets. The doctor will base the dosage on the weight and body surface. Methotrexate can be given as an injection under the skin, which is more commonly used. Doctors mainly use azathiopurine as an immunosuppressant as well. It's also used as a maintenance medication. This is a part of the remission maintenance phase. It's vital to ensure that the patient gradually reduces the dosage of their medication, so their body does not go into a shock if stopped. It's prescribed towards the end of the vasculitis treatment in people with small or medium vessel vasculitis. Doctors usually perform a blood test called TPMT, which detects a natural body enzyme, thiopurine methyltransferase, which breaks down the medication because once azathiopurine is introduced to the body, it's immediately converted to 6-mercap top urine. This can be toxic, so the body needs TPMT to deactivate it. People who do not make this enzyme cannot take azathiopurine, and people with lower amounts will need to be treated cautiously with a smaller dose. For those who have the preferred enzyme amount of the dose, amount of enzyme, the dosage is usually based on body weight and may receive a single or double dose. So in some cases of vasculitis, patients will need to be referred to have surgery. This will depend on how severe the area affected is. There are two types of surgery. There's angioplasty and bypass surgery. In angioplasty, a short wire tube, also known as a stent, is inserted into the artery. The stent is then kept in the artery to ensure and allow the blood to flow more freely. During bypass surgery, surgeons take a part of the healthy blood vessel, either from inside the individual's chest wall or from their lower leg, and attach it above and below the blocked artery to restore blood flow.
Yeah.
So there are a lot of complications that can happen with some of the medication that is used. The first is for cyclophosphamide. It's an immunosuppressive drug and is normally used alongside another steroid, which is prednisone. It helps to decrease the dose of steroids that are needed. However, it includes side effects such as an increased risk of infection. These infections are opportunistic infections that normally don't affect your health, but when your immune system is suppressed, it can have a negative effect. Another bad effect is bone marrow suppression. This is where red blood cells, white blood cells, and platelets are made. Almost all patients experience bone marrow suppression, and so it is vital to monitor blood counts during treatment to ensure they don't fall too low. If blood counts fall too low, patients are at risk to anemia, which is when there is a decrease in red blood cells, neutropenia, this is a decrease in neutrophils, thrombocytopenia, which is a decrease in platelets, and pancytopenia. Bladder problems such as hemorrhagic cystitis can also occur. This will result in bleeding from the bladder. This can range from a few cells to a fatal hemorrhage. If any blood is found in the bladder, the medication should be stopped immediately. Cyclophosphamide also increases the risk of cancer. This risk of cancer can remain for years, even after patients have stopped the medication. The risk of cancer depends upon the length of time patients have taken the medication and the cumulative dosage of the drug. Types of cancer that patients are more at risk for include bladder cancer and leukemia. That's not the right slide. Can you go back to like the first slide with all the list of, Rituximab is a monoclonal antibody. It targets a protein called CD20 on the surface of cells. Rituximab sticks to all these C20 proteins it finds. Then the cells of the immune system picks out the marked cells and kills them. The side effects of rituximab include increased infection risk, increased bruising and bleeding caused by a drop in the number of platelets in the blood, nausea and hair loss. Severe side effects include progressive multifocal leukoencephalon and reactivation of hepatitis B, which remains dormant in your system after initial infection. This is a rare and fatal viral disease characterized by the progressive damage or inflammation of the white matter of the brain. It is caused by the JC virus, which is normally present and kept under control by the immune system. The JC virus is harmless, except in the case of a weakened immune system, such as when taking immunosuppressants. PML has a mortality rate of 30% to 50% in the first few months, and those who survive can be left with varying degrees of neurological disabilities. Azathioprine is an immunosuppressive drug. The common side effects include bone marrow suppression, vomiting, increased risk of certain cancers, and using it during pregnancy may result in harm to the baby. Serious side effects include gastrointestinal drug hypersensitivity and pancreatitis. And we've already done that. MTX often helps patients avoid cyclophosphamide and decreases patient needs for steroids. Common side effects include loss of appetite, feeling or being sick, stomachache or indigestion, diarrhea, headaches, feeling tired or drowsy, hair loss, and there are more serious side effects. I think the next slide from this, not the arrow. Liver problems that can cause scarring or cirrhosis, pneumonitis, which is inflammation of the lungs. Symptoms include a persistent cough, chest pain, and difficulty breathing. Blood disorders, i.e. anemia, thrombocytopenia, and leukemia. And Stevens-Johnson syndrome, which is a rare serious disorder of the skin and mucous membranes. It is usually a reaction to medication that starts with flu-like symptoms and is followed by a painful rash that spreads and blisters. It can take weeks or months to recover.
There are many foundations that are able to help raise awareness of vasculitis. I'll be discussing the Vasculitis Foundation. The Vasculitis Foundation campaigns for early diagnosis, leading-edge treatment, research, and ultimately hopes to find a cure for all types of vasculitis. They are a team of caregivers, researchers, data specialists, providers, and patients with vasculitis. The foundation supports and encourages patients via education and awareness. The Vasculitis Foundation are able to do this by their bi-monthly newsletter, medical consultants, webinars, chapters, support groups, and contacts. They have made many discoveries and advances in vasculitis research. For example, some of their most recent discoveries are the diagnostic delays in vasculitis and factors associated with time to diagnosis and accuracy of self-reported diagnosis of anti-neutrophil cytoplasmic antibodies associated with vasculitis, and many more. So 80.7% of people with vasculitis are women. Women are more likely to have vasculitis due to them having more VGLL3. This is a protein that's responsible for regulating the immune response genes, which have further been implied to play a crucial role when it comes down to autoimmune diseases. Having too much VGLL3 in skin cells pushes the immune system into overuse, leading to a self-attacking autoimmune response. 57.6% cannot lead a normal life, and 60.6% of people affected by vasculitis are not working. Vasculitis patients who are able to go back to work are granted breaks whenever they need them. However, some may not be able to go back, as vasculitis may cause disabilities that could make it harder for them. 44.4% feel the same as a year ago, 33.3% feel better, and 22.2% feel worse. At 84% of vasculitis patients are on treatment. Sadly, this is not at 100%. So this could be due to the lack of research, or maybe they're living in a less developed country. Others may not be taking the correct treatment as they may not have been diagnosed yet. Most common signs and symptoms are fatigue, joint pain, and weaknesses, and vasculitis lasts for an average of 8.08 years. It lasts for an average of 8.08 years, possibly because of how different bodies react to treatment in different ways. For example, some may need a longer time to react with the medication, whereas others may respond rapidly. And others who are not able to lead a normal life may be having difficulty with their vasculitis due to it being known to cause other diseases, for example, organ damage. This can be due to the vasculitis being severe, and this could result in organ damage. It can also be related to blood clots and aneurysm. When a blood clot forms in a vessel, it will block the flow of blood, and in very rare cases of vasculitis, this will cause the blood vessel to become weak and an abnormal bulge resulting in an aneurysm. Vision loss or blindness can also be due to the complications in untreated giant cell arteritis and infections due to some of the side effects of the treatments of vasculitis, which may weaken the immune system, making the patient more prone to infections.
It is very important for people to be aware of conditions like this, Like many conditions such as cancer and diabetes, recognizing symptoms allows sufferers to have an early diagnosis and hopefully stop the disease progressing too far and potentially save a life. If people are aware of the symptoms and the consequences of a condition such as vasculitis, they are more likely to take action to help prevent it happening to them or go to healthcare providers for checkups. There are a number of charities and foundations set up to raise money and awareness for vasculitis. One of these is the Laurie Curie Twilight Foundation. The Laurie Curie Twilight Foundation is a charity committed to providing support for people affected by vasculitis. Since 2010, sustainable support services and educational initiatives, progressive campaigns, and high-profile events have made LCTF a driving force for the vasculitis community in Scotland and the UK. The charity has raised over £800,000 to fund patient support, awareness campaigning, and medical research. Laurie Curie was 15 when she died from Wegener's granulocytitis. The Laurie Curie Twilight Foundation was set up in her legacy. The Twilight Foundation reflects her last obsession, the Twilight Saga. The Twilight Foundation we have created in Lauren's name also reflects her last obsession, the Twilight Saga. The novels on the bookcase are well thumbed and have been read many times from cover to cover. A sea of posters covers her bedroom wall. A 6-foot cutout of Edward Cullen, which was often planted outside her bedroom door as she delighted in hearing us jump in fright, still stands menacingly in the corner. Books, calendars, action figures, t-shirts, cinema tickets, games. We refused to call our new puppet Edward, so a compromise of Eddie was reached. It seemed only fitting that the last name of Twilight was incorporated into the charity. This is Lauren's charity, founded through our love of our daughter and everything she represented.
Doctors treating patients with vasculitis rely on clinical and trials and research being conducted and published to know what the best treatments for different types of vasculitis. This means that the recommendation for treating some types of disease keep changing as they understand more about them and how to treat them. Unfortunately, more types of vasculitis are rare. This makes them very difficult to do useful research and conduct clinical trials to find the best treatments. Fortunately, there are groups of doctors around the world interested in finding better treatments for vasculitis, and by cooperating together, research gets done and treatment becomes safer and more effective.
Consent will be needed from patients when it comes to treatment. This is because of it being a patient's choice to continue with the treatment. This comes under the ethical pillar of autonomy. Doctors will have to ensure that they do no harm and that the patient feels pain. Then if patient feels pain, then it must be unavoidable. It's important to be compassionate with a person with this condition as they're going through a lot of pain and treatment. One of the NHS values is improving lives. With treatment, the quality of life of anyone with this condition can be improved. Additionally, other values are improving lives and commitment to quality of care. Some patients may have difficulty understanding what is happening with them, so medical staff need to be patient with them and help them whenever.
If you're being treated in a clinic that is involved in vasculitis research and clinical trials, you may be invited to take part. If so, the medical team should explain the nature of research and clinical trials to you, give you information sheets to look at, explain the possible pros and cons for you as a patient in taking part, give you the opportunity to ask questions you might have and for them to give you answers, and respect your decision about taking part whether you choose to participate or not. Sometimes you may benefit directly from taking part in the clinical trial or research. Sometimes only other patients in the future will benefit from you having agreed to take part. Thank you for listening.
Thank you, team. Team led by Mena, Maisha, Shadan, and Kitchen. You guys chose a very difficult topic to present. It's not easy. Vasculitis is always difficult even to diagnose, and the presentation can be so varied. So once you have the diagnosis, the treatment is all there. It's we can read and do it. But to get to the diagnosis, I think in medicine, that is the art is to getting to the diagnosis. So you guys are getting a window of opportunity now to learn all these tongue-twisting names, and sometimes which can be amusing. I could see that the speech to text was playing up a little bit. Probably it only recognizes one person's voice there. Probably Mena, it must be belonging to you, Mena, the software. So it has learned your the way you speak. So the condition itself is sometimes classified as rare because it's not so often recognized and diagnosed. And people do go through a long period of time of multiple investigations before it. Mentioned in the beginning, big vessels, medium-sized vessels, or small artery vasculitis, and biopsy of the skin or the artery, or sometimes kidneys, because kidneys have a lot of small arteries, and you take a piece of it and you can see the changes in the very small arteries. So overall, a very good presentation, brilliant, even though it was quite difficult with a lot of medication. Respect to those and presented it in a very good way. So no questions from my side, because there's no point in asking question on these things, because it's such a difficult, even if you go and speak to any medics or a GP, they will be finding it difficult to recognize these things. But I understand this exercise is more of you guys trying to look into what you're going to do next in the future, and how difficult or how easy you're going to choose a career which is amazing in terms of work. Not each day is the same day, every day. Medicine or any of the medical specialties, the first step is service and patient care. Money is always a byproduct of it. So all the best to you guys. Do well. I'm sure you'll be progressing to great lengths in your career. Good luck.
Thank you very much. We actually have one question for you on the Slido, which is, since there are so many complications for these medications, how does a doctor prevent a patient from becoming worried?
So when you consider any medication, they all come with their side effects, and the idea is to use any intervention and weigh the risks and the benefits of the intervention. If the benefits are there in a balanced way, and it is needed, if they need that medication, they will definitely need to have this, because the benefits outweigh the risks of not having it. However, you have to be very truthful, straightforward, transparent with your patient to explain what are the complications that we can expect, how to recognize these complications early. That's the key here. And as long as that information is given in a transparent way, it could be written leaflets or links to websites, or sometimes we give them a small information leaflet or a card to carry with them all the time. You may see some patients wear some bracelets to say that, look, I'm on steroids, and if I collapse, please make sure that I get my steroids through an injection or an IV line immediately, because they're life-saving. So every medication you prescribe comes with its side effects and complications. And the medications what the team just mentioned, they're all very toxic ones, which can cause other problems, which was highlighted there. So it's education, getting your patient on board, communication with them, and their trust in you, that they know that my doc is doing the right stuff. That only comes up as you build the rapport with your patient and the trust is developed. So they place their health in your hands, and we have to walk with them throughout these days when they are on the treatment, and and they get in touch with you in between your clinic appointments. They may want to speak to you. So these are the things that we do often to address any of the issues that come in between. So that's the reason medicine is a challenging job. And when they select the guys who want to go into medicine, they want to select the people with the right attitude. That's the reason for all the exams and the UK CAT, and to select those people who have the resilience to do it. It's quite important that you have the resilience to do this kind of a job, even though it might appear as a very simple one on the top, but on a day-to-day basis, you're dealing with people's lives. So yes, so develop the trust, confidence, rapport with your patients, and be honest. These are the things that we do day in and out to keep the patients aware of what to look for. Okay.
Thank you very much. That's
I've
really
answered
useful.
your question, Namita. I don't know whether I've answered or not, but it's a long drawn one.
Yeah, that's perfect. That's even more than what the question was, so that's brilliant for everyone. So I think we have one more question that's for the group that presented.
Okay.
So that question is, can vasculitis come back after being treated?
I can answer that question for you guys. Yes, it can come back. Vasculitis is most of the times kept at bay by treatment, and you suppress the autoimmunity or the process, and they may have to need multiple treatments, and the relapse can happen. Yes.
Okay, thank you very much, Dr. Eligar.
Thank
So
you.
that's
You're
all of
welcome.
the groups done now. So we will give the feedback that Dr. Eligar has done back to all of the groups very soon. So thank you so much for coming today.
Thank you very
It's
much.
been
Give me
really
another 1 hour or 2 hours. I'll fill up the forms and send it back to you guys.
Yeah, that's perfect. Thank you.
Bye.
And so next we have a speaker from the charity that we've been raising money for, from AIMS, AIMS. So I'm going to let Alison talk to us about the charity, and please, please, please donate. I think we'll put the link in the chat box once again.
Lovely. Thank you very much for having me here today. Yeah, I'm Alison Coates, and I am from AIMS charity, which is Autoimmune and Multiple Sclerosis. I'm going to share a presentation with you today, which really just sort of covers who we are, what we do, but also we wanted to talk a little bit about the autoimmune community and how they're feeling at the moment in light of the relaxation of the COVID restrictions that have been happening. So if you can just bear with me while I share my PowerPoint. Okay, hopefully everybody can see that. If you can't, please speak up. So we are a charity that works with hematologically rooted autoimmune disease. And we are the first charity of our kind in the UK, and we're the first charity in the world that actually offers financial support in terms of a particular treatment of these diseases. So just a little word about the autoimmune community in 2021 and sort of how they're feeling. We've had a lot of feedback in the community that we work with about how they are feeling about these things. And we've got different demographics as well within this autoimmune community. So we know that there are 4 million in the UK with an autoimmune disorder. We've got the most common in front of you here, the top 4. And as I said, we work with MS patients particularly, and those who've got hematologically rooted autoimmune diseases. So in terms of lifting of these COVID restrictions in 2021, and thinking specifically about people with MS, although of course this is a lot broader an issue, but sort of focusing on people with MS, we wanted to sort of look at the people in those different groups and what the problems are that are facing them. So the first group is the group that are on these 3 drugs, because these 3 DMTs, the disease modifying treatments, they lower a person's immunity. So they make that person more susceptible to any infection to start with. So this is a group that will have concerns, because they're going to be worried that they are going to be more susceptible to COVID in the first place. But then we also have another group of people who are on particular medications that reduce the autoimmune, the immune response to the vaccine itself. So there's a little bit of information here about that. Most people who are being treated with a disease modifying treatment, they're going to be perfectly all right, and the vaccine is going to be suitable for them. But we have got these 2 medications, which are medications that people are on in the UK. We've got fingolimod, also known as Guillain, and we've got ocrelizumab, which is Ocrevus. And we've only had 22.7% in the case of Ocrevus and 3.8% in the case of the Guillain, that of this population that have developed the protective antibodies. So again, this is worrying for anybody that's on those treatments, because they're not just going to be able to stop, because that's what's holding their MS at bay. We also have a group of people that have undergone HSCT, which is hematopoietic stem cell transplant. And this is really the group that we advocate for. We try and share the information about HSCT, because HSCT halts progression in the overwhelming majority of people with MS, no matter what stage their disease is at, whether it is relapsing, remitting, or it's progressive MS. So we have a group of people who are fearful of vaccination or revaccination, having undergone HSCT, because we have different recommendations from different centres. So some centres will say to their patients, yes, you must have all your vaccines. Again, it's very important to get them. We have other centres that say, well, actually, it could provoke an immune response. It could kick your MS back into action. We recommend that you perhaps don't. And also we have patients that will undergo a titer test that will show that they have retained immunity for a lot of the vaccinations that they've undergone anyway. In my husband's case, this was how it was for him. So he didn't need any revaccination because he had retained that immunity. But there is a lot of fear and there is a lot of concern from people in the autoimmune community who do feel that perhaps this is going to put them at a vulnerability if they have these vaccinations. And the research that exists does show that probably there is very little correlation between vaccinations and people who go on to develop MS. But the whole field of epigenetics, the idea that genes loads the gun and environment pulls the trigger, is definitely something that is on a lot of people's mind in the MS community. So it's certainly something that they are worried about. And then finally, we have this group of people who have undergone HSCT in the last 12 months. And as we said, HSCT is used for hematologically rooted autoimmune diseases, such as this list here. So this is a list of conditions that are treated around the world in different centres. So some centres will treat most of these, some will treat some of them, some will predominantly just treat MS. But if you have had a stem cell transplant, whether it's for MS or it's for cancer, it's for leukemia, whatever it might be, that is going to reduce your immunity for the next 12 months or so. So anybody that's undergone that process is treading very carefully at the moment and is very, very concerned. Now, in the UK, there are only 250 that have undergone this process for MS in the last 7 years. More broadly speaking, the two key centres for HSCT for MS are in Russia and in Mexico, and they've treated over 3,000 between the two of them now. So this is an ongoing situation. It is something that was paused briefly during COVID, but these hospitals now have their doors open for business again, and people are undergoing HSCT as we speak in the UK and internationally as well. So that was just sort of a little bit about how the community is feeling at the moment, the things that they have told us that we sort of wanted to feed back to you, so you can sort of see it from a patient perspective, because we are very much a peer-led charity. So everybody who is on our board either has MS, has had HSCT, or has been impacted by it in some way. So they are really speaking from personal experience and not from an ivory tower, which is what we see with some other charities. So I wanted to talk to you a little bit about my husband's story and his journey to establish AIMS with me, because we founded this charity together. And funnily enough, today it is exactly 5 years to the day since he had his stem cell transplant at King's College Hospital in London. He is doing very, very well. He's actually out with our daughter at somewhere at the moment. They've gone off somewhere. And it really has been a life changer for us. But I will come to that a little bit later on and sort of what that's meant for him. So in terms of how this first manifested, his very first symptoms were probably about 15 years ago, and he presented with optic neuritis. So he had an MRI, he had various tests and so on. Nobody mentioned MS at that time at all, and the optic neuritis went away. And it was only with hindsight that we were told, actually, this is a sign of MS. It's quite often a first warning sign. So he went quite happily for the next couple of years or so, and then he had some problems with his legs. So one of his legs was not doing what he was telling it. It was his foot was dragging. He had foot drop. So after a lot of nagging from me, he finally went to the doctor and got this checked out. He was referred. He had a lumbar puncture. He had blood tests that revealed the oligoclonal bands, and he was diagnosed with MS. Now, he was diagnosed variously at different times with progressive MS, primary progressive MS, relapsing remitting MS, and secondary progressive MS. So how that works, who knows? But ultimately, they decided that he had secondary progressive MS. So over the next couple of years, we did whatever we could really to research what would be best for him, to try anything and everything that could help him, from diet to low-dose naltrexone, which has been shown to help a number of people, to Reiki, to other complementary therapies, you name it, we pretty much tried it. He was put on a trial called MS Smart, because at that time there was nothing available at all for secondary progressive MS, so no medications on offer. And he progressed really very quickly over the space of perhaps 2 years, from a disability level of 1 to EDSS 6.5. So that meant that he was walking with a stick most of the time. He was using a mobility scooter. His disability was not good. He was in a bad way with a lot of different symptoms. And it seemed that certainly before he had HSCT, that these symptoms were getting more and more, almost on a weekly basis. So you can imagine how frightening that can be for the person that's experiencing it, but also for their family as well. So what did we learn on our journey? Well, the first thing that we learned very, very quickly was that neurologists are not the experts when it comes to HSCT, but sadly they are the gatekeepers of this treatment, when actually it is the hematologists that are the specialists when it comes to HSCT. So what we found very quickly was that a lot of neurologists were actually very uninformed when it came to HSCT, and the information that they were giving us was either outdated or they just didn't know about it at all. So at one point we went to a conference and that was with neurologists and hematologists, and a neurologist stood up and said to the assembled hematologists, you know, what are we supposed to do? We've got people that want this treatment and we don't know anything about it. You know, we only know what we're told when we come to these conferences. So what are we supposed to do? You know, it's really very inconvenient, which was probably the wrong thing to say to a room that also had people with MS in it, because we had one person who stood up and really took this chap to task and said, you know, I've spent the last 2 years researching anything that will help me to stop my progression. I've just come back from Mexico where I've had a stem cell transplant. I researched it. Why haven't you researched it? You have a duty of care to your patients. This isn't good enough. We didn't see that neurologist after the coffee break. He didn't come back again. But this illustrates really sort of what we see all the time. So we're hearing inflated death rates. We are hearing neurologists who say to their patients, if you have this treatment, you will come back in a box. We are hearing that it's a scam, that it doesn't do what it's supposed to do. But the fact is, this is a treatment that is available on the NHS. It isn't under trial. It's a treatment that's been used for MS for over 20 years. So, you know, the evidence is there. That brings me really to the barriers to treatment in the UK. When my husband was assessed for this treatment, it was still very little known for MS in the UK. In fact, he was the 17th person to be accepted for it. So our neurologist actually asked us if we could spell hematopoietic when we first inquired about it. So, you know, we knew we were barking up the wrong tree there. So we found the specialists ourselves and we applied. And initially my husband was rejected because he didn't meet the criteria in that he didn't have active lesions and he didn't have new T2 lesions. But we knew there was evidence out there that showed that HSCT can support even these people, because even though the evidence is not there on an MRI, there can be a number of reasons for this, but we know that there is still very likely hidden inflammation, which is beyond the blood-brain barrier and isn't going to be picked up by an MRI. We also know that if a little more gadolinium is given and that there is a longer wait period between administering the gadolinium and having the scan, that will also pick up more active lesions, and so more people will be eligible. So he was very lucky to get this treatment, and he's done very well. In fact, he's thrived since he's had this treatment, which I think is probably a little inconvenient because it doesn't quite match the criteria, which have considerably tightened up since this was something that was featured on Panorama. So we also found how important it was to self-advocate. And for a lot of patients with MS, this is very, very difficult to do, because if they don't have the right support network around them, they're not going to be able to do that. A lot of them have cognitive impairment. They don't have the strength or the will or the acumen to be able to self-advocate. Research, again, absolutely key, because there is so much research out there on this topic, and if you are armed with that research, that's going to help you in the long run. And of course, we found out about HSCT itself. So this is the process for HSCT in the UK particularly. So when a patient is accepted for HSCT, the first phase is what they call mobilization. So some chemotherapy is given, a little chemotherapy, and GCSF injections, which mobilize the stem cells into the bloodstream, and they are then harvested. At this point, usually the patient will stay very close to the hospital for about 3 weeks or so in case there is a problem, so that they can get back in and they can see the specialists. So in James's case, we're from Lancashire. We had to base ourselves in London for a month while he underwent the mobilization. And then the patient is sent home for a month or two to recover from that initial process. And then they come back and they are in hospital for the best part of a month, where they undergo further heavier chemotherapy plus a drug called RATG or rituximab, which is the drug that is favored overseas. And then when their immune system has been mostly ablated, because in the UK they use non-myelo HSCT, which means that they don't completely ablate the immune system. So the stem cells that have been harvested really just help to restart an immune system faster. If they have myelo HSCT, which is offered in some parts of the world, without that stem cell rescue, the patient would die because they've had their immune system completely ablated. It's 90-something% in the UK and Mexico and in Russia with non-myelo. So the stem cells are reinfused. And as I said, it's exactly 5 years today since my husband got his stem cells back. If I had thought, I would have put a video into this PowerPoint, because we actually have the video of the stem cells going back into his body. Okay, so what we learned after he'd had HSCT, we learned about the challenges that are going to come after a treatment like this, because it is an intensive treatment. You know, this is chemotherapy, it's heavy going. So I needed to take a little time off to look after James when he came out of hospital. We were very lucky. There was a lot of NHS support available for us because he had had that in the UK. In the cases of people who've had it overseas, that can be a little bit more difficult. And of course, we have a much higher number of people going overseas because they don't meet the criteria here. We found out what the percentage of people who have had HSCT in the UK for MS is, and it is 0.2 of the entire population of MS patients in the UK, because there are over 130,000. So it's pretty low. So when we're being told, well, you know, people aren't meeting the criteria, we have to question that, because it seems unlikely that only 0.2 of these patients would meet that criteria. We found that HSCT is effective for most people with MS, including those with progressive disease. And this is really a stumbling block, because what we find is that a lot of medical professionals are really looking for the holy grail. They're looking for the cure. They want to be able to say to their patient, this will work for you, it will reverse your symptoms, and so on. In terms of people with progressive MS, a lot of the damage that's already been done is permanent damage. And so it's not going to be undone. But HSCT can halt their progression, and we hear so much that for many people who are getting worse on a weekly basis, which is how it can be with MS, they are happy to halt their progression, and any symptomatic relief is a bonus. For those that have highly active relapsing remitting MS, they find that symptoms are reversed as well. You know, the EDSS can be reversed significantly, but what we're trying to convey is that quality of life can be improved enormously, and progression can be halted for those that have got the progressive disease. Not everybody, you know, nothing is for everybody. Some people will be too progressed for this to be effective for them, but that is up to the specialists to decide at the different centres. And what we want is for patients to know about this treatment, to be able to discuss this option with people that understand it and know it themselves and aren't giving them the wrong information, which brings me to the next point. We're still hearing on an almost daily basis information that we know to be untrue, and whether it is just that these neurologists have not updated the information, or they're not aware of the latest research that's come out. There is some research that came out of King's College Hospital in the last week that that was spoken about on the radio. One of our supporters who is having HSCT was able to talk on the radio, and the MS Society was on the radio as well. They didn't even seem aware of this research, which shows very clearly that it isn't just relapsing remitting patients that it's suitable for. This was a cohort of primary progressive and secondary progressive patients as well. And the overwhelming response was that it halted progression long term, not just for a few months. And again, the last thing that really came home to us was that this importance of a support network, because this is too big for people to fight on their own. They need that support, they need that knowledge, they need the experience. This is a tracker that I made for my husband before he went into hospital. And interestingly, when we went to a conference in Russia, an HSCT conference in Russia, they actually had produced something very similar. So it was a very personal tracker of the patient's symptoms, because they call MS the snowflake disease, not because patients are snowflakes, quite the opposite, but because each one is different. And so the symptoms that you will see them present with are very different. So we marked them out of 10, with 10 being the worst possible, you know. So he really had some symptoms that were very, very bad. Then we marked them again at 6 months post HSCT, and we marked them again at 12 months post HSCT, and we mark them again every year. So we do this around this sort of time. And you can see that every one of those symptoms from pre-HSCT to post-HSCT, with the exception of his foot drop, because that is the thing that's being caused by this permanent damage. It isn't something that can be undone. It's a little like a war wound, if you like. So he is the walking wounded. He's still got this issue with his foot drop. He is medically disabled, so his EDSS is still 6.5. That hasn't changed. But you can see by the quality of life improvements, this has been a successful procedure for him, even though on paper it wasn't, you know. So this is the problem. This is how much HSCT can improve somebody's life. And again, not for everybody. Some people are non-responders. Some people will get worse, and they don't really know why that is. You know, it can, and anybody, relapsing, remitting, primary progressive, secondary progressive, it doesn't mean that you're from one group, you're definitely going to get worse. But as you see, for James, it's been phenomenal. It really has. Okay, why we need aims. I thought probably the best way to get this over to you would be to share this video that we made some time ago with people from all over the world who have had HSCT and what it's done for them. So this is just a 5-minute video just to sort of finish off. I'm going to play this for you now if it's going to cooperate with me.
What I didn't realize is how much hope I would have for the future. And I didn't realize I didn't have hope until I found out about HSCT, and then I started having hope.
I went to Mexico for HSCT because I'd previously applied to Dignitas to end my life, as I am a high EDSS score and thought there was no hope for me. The improvements were instant. My legs are back to a normal colour. I can now move them. My fatigue is gone and my bladder is back to normal.
I have my fit with my family again, and I no longer have MS.
So I had HSCT 9 months ago for my secondary progressive MS. Not only has my progression stopped, but every single symptom has improved, and I have had no more foot drop since transplant.
I'm here today cycling around Lady Bower Reservoir. I'm 2 years without any relapses or active progression. I've had less symptoms. My leg's not collapsed for over a year and a half, and I've not had Lynette's syndrome either for exactly the same amount of time.
Just to say how grateful I am to have been able to have HSCT in Moscow in March 2017. It's a complete game changer.
I had HSCT 21 months ago for my secondary progressive multiple sclerosis. There's 3 main reasons why I'm really glad that I did it. Firstly, all progression has been halted so far. Secondly, I've had improvements in balance, fatigue and brain fog. And thirdly, it means I can look forward to the future instead of worrying about how I'll be in the future.
Thanks to HSCT, I don't have any pain anymore. I don't have any heat intolerance, and I don't have any fatigue anymore. I can spend full days at the beach in the sun. I've got the energy to chase my little boys around. I don't have to nap anymore. I've got the energy to be the mum that I want to be again. It's given me my life back.
I'm now 10 and a half months post HSCT. I'm 6 months off being qualified with my degree, and I'm confident that I'm going to hit the workforce running next year. I'm also walking a long way. It's awesome, and I would just like to say thank you, Moscow.
I'm 5 weeks post-treatment, improvement so far, less stiffness in my legs, bladder improvement, pins and needles in my hands are improving, and I'm saving a fortune on shampoo.
I'm 1 year post HSCT,
And the big improvements for me are the 3 Bs: my bowels, my bladder, and my balance. It's been absolutely incredible. I thank Dr. Rees every day for giving me my life back.
Hi, just gone up 10 months post. My bladder, my balance, and my swallowing are all much improved. Brain fog is lifting, and I feel like I'm getting me back.
Since having HSCT, my fatigue is almost gone. I can do things like a normal person. It's amazing.
I'm 20 months post HSCT. For me, it's like winning the lottery. My bonus wins include improved strength, no tremor, which in turn means I can wear earrings, put on lipstick, and hold a glass of drink without spilling it. HSCT rocks. Cheers.
I'm 14 months post-treatment. I firmly believe that the treatment has stopped my progression. I was 6.5 ADSS score. The improvements I've seen are my bladder and bowel are better. Fatigue has lifted. Still have problems with fatigue, but not half as bad as they were. So yeah, I definitely recommend HSCT to any MS sufferer.
HSCT absolutely rocks. I had a fantastic day out yesterday with my mum. We went to the theatre, ate good food, drank wine, and I wore heels all day long. Well, kind of heels. Last year we went to the theatre, I fell, I took my stick, I couldn't walk. My EDSS is now 2.5, whereas it was 5.5.
Hi, 14 months post HSCT. Improvements are far less fatigue. Walking is a little better sometimes. It's probably the only chance you'll get at doing anything. And I actually go to the gym twice a week now and swimming once a week. I'm really not sure I could have done that earlier.
It's allowed me and my family to dream again and plan for the future again without having to factor in where I might be with my disease. Will I be disabled completely? Will I need nursing care? Will we need to budget for that? I can travel again. We can take trips again. It's really the best gift I've ever given myself.
Okay, so yeah, in that video, you saw a lady at the very beginning who was saying that she had planned to go to Dignitas, and she had, that's where she was up to. It's actually, she was treated around the same time as James. It's actually her birthday today, not her HSCT birthday, but her real birthday. And she's still there, she's enjoying life. Dignitas is absolutely off the agenda. The guy who joked about saving a fortune on shampoo, he is now one of our trustees because he believes so strongly in it. And we have a lady who is probably about 10 years post HSCT now, and she's in America, and she is coming over to run the London Marathon for us this year. So it just goes to show what a huge difference this can make to people's lives. So I'm just finishing off now. This is really what our remit is: to inform, to signpost, and to support. This is how we do it with our website, with our social media, and through events. This list is really what we have achieved so far, because we are still a very young charity. We launched in 2018. but these are the things that we have achieved so far within that time. One of the things I think we're most proud about is that we have been able to financially support more than 20 HSCT MS patients who've been treated in the UK, Mexico and Russia with travel grants of up to £1,000. Which is a drop in the ocean of the cost of it if they're having to have it privately. But we give that funding to people who are having it on the NHS as well, because nobody really should be in the position where they should be out of pocket for a disease like MS. So we will support anybody who has MS. And these are the things that we want to achieve next. So we want to continue doing what we've done. We want to raise more money for people undergoing HSCT. We've now attracted grants. We want to be doing more of that. And we would really like to start employing staff, because it is getting to the point now where we are a team of volunteers. Every single one of us in this charity is doing it for free out of the goodness of our hearts, because we passionately believe in it. But we are getting to the point now where it's a lot to do, particularly when a lot of us are employed as well. So we want to be able to get to the point where we can deliver the project with employed staff. And we really want to continue working with practitioners and people like yourselves to just get the word out there, because it's so important. So we are contactable this way. We're on all the social media. And of course, you have the just giving information. I'll bring this slide back up at the end, but I'm just going to stop sharing for a moment. Come back out. And so we're so grateful for the support that you're giving us today and giving us this platform to talk to you. I'm very happy to answer any questions if you want to ask any questions. I realize we're right at the end of your time here, so if you don't, that's absolutely fine. But if there's anything that we can tell you, I'm happy to do that.
Thank you very much. That was really useful for all of us, because it's nice to hear from your experience, because you know people that have had to deal with it, which is great, because it gives us that sort of insight.
Yeah, it's a different perspective, isn't it?
Yeah, exactly. So we do actually have a couple questions from people that have just typed in on, so I can read them out to you. The first one is, can you summarize what the eligibility criteria is for HSCT?
Yeah, so if you were to go overseas, pretty much the eligibility criteria is, do you have MS? Unless you are progressed to the point that even getting you over there is really, it's too far. But in Mexico, they will treat people who are in a wheelchair. And I believe in Russia, they will treat people with an EDSS of up to 7 because of the infrastructure that they have there and so on. In the UK, it is a lot tougher. So if you are in Ireland, Wales or Scotland, you can pretty much forget about it, because although you should be eligible to get it, not a single person from any of those places has got HSCT on the NHS yet. As I said, 250 in England have managed to get it, which is only 0.2% of the population. So if you have relapsing remitting MS, you must have failed one of Tysabri or Lemtrada. So that means that they want to see radiographical evidence you've still got lesions even though you have been on this particular drug. That's the first thing. You also need to show either 1 new active lesion or 2 new T2 lesions when compared to a scan that is under 12 months old. Now, an active lesion is going to last for 30 to 40 days. So if you are on the edge of progressive, it's a lot less likely that's going to show up on your scan to start with. But they will accept in London the T2 lesions, which is really good news for people that are progressive, because that's a little more likely for them. In Sheffield, no, it has to be the active lesions. You have to be relapsing remitting. If you are secondary progressive or primary progressive, as I said, they want to see those lesions, but there isn't this question of you must fail the drugs first of all. You also need to be under 65, and you need to have been diagnosed up to 15 years ago. Anything over that, they're not really keen on. The full criteria for London is on our website, which is aimscharity.org. So there's a lot of information on there. There is also an article, an exclusive article from Dr. Majid Kazmi, who is really the lead haematologist. He's done probably more than anybody in the UK. So there is his perspective on there as well. So yeah, that's pretty much the criteria in a nutshell.
Okay, perfect. Thank you. And just before I move on to the questions, I was wondering if you would be okay for us to use some screenshots to put on the Instagram. And
absolutely, yes, that's fine.
Yeah, okay, perfect. Thank you. And another question is, what exactly can us as future medical students do to help this cause, and where do these donations go to?
Okay, so the donations, and thank you so much if you have been donating. Honestly, it really does mean so much. As we said, we are volunteers, so every penny raised goes to the recipients. And the way that we work is that we open funding rounds every 3 months for people who have been accepted and have a date confirmed in either Russia, the UK, or in Mexico. And what that means is that any contribution from us is not just going into their funding pot and they might not actually get there. We give it to people who have the money raised, who are definitely going on this journey. So we invite applications, and really the main criterion is, have you got an approved date? Are you definitely going to have it? Have you raised the money for it? And if they tick those boxes, that puts them then through to our second round. And that means then that we're asking, what is the cost of your travel expenses and so on? And they get the cost back when they have been, and we have got the receipts. We give them that money. So as I say, that's done 4 times a year. And yeah, that's the way that we operate at the moment. But the grants that we have been attracting, and I think that's probably how we will always want to operate in terms of the funds that we are raising, through people that are doing sponsored events for us, for people that have had this and are making donations to help other people. You know, we want every single penny of that to go towards those people. In terms of the projects that we're now attracting the grant funding, that's the money that we want to use not only to pilot projects, but also to pay people, because that's part of what we have to do in order to get the project money. Part of it is that we need to employ people basically to do that. But the funds raised through our own fundraisers, through the things that people are doing for us, as far as I'm concerned, that's ring fence. That's just for them. We are not a charity where any of us envisages earning 6 figures in years to come. We don't want to do that. That's not what it's about. It's about helping people.
Definitely. And another question says, what advice would you give to, for example, an aspiring neurologist on how to improve the treatments for those suffering with MS?
Yeah. I would say, gosh, going back to a Labour phrase from many years ago, education, education, education. I think I would want them to speak to the haematologists that have been involved in this treatment. I would want them to speak to the neurologists who are on the MDTs in London, in Sheffield, all over the world. I would want them to speak to the haematologists that have been delivering this treatment to thousands of people in Mexico, in Russia, with great effect, because there seems to be almost an element of snobbery. Oh no, Mexico, it's a third world, you can't go there, it's not. And actually it's the exact opposite. What we hear is that the care could not be any better. The hygiene is incredible, and the care is just superb. So we would say, don't just dismiss it because it isn't part of your field of experience, because it isn't a disease modifying treatment. Work with the other disciplines. So I think this idea of multidisciplinary teams is really something that is growing, but it's not quite filtered down yet to all the neurologists, and that's what we want. We want to share this message.
Okay, thank you very much. That's all of the questions that have been asked.
You're welcome.
very, very, very helpful for everyone. So thank you so much. And we will make sure that we keep posting that link for people to donate. So
brilliant. And do tag us in anything that you put on Twitter or social media as well, because we'll reshare that too. But
okay, perfect.
Yeah, thank you so much for the opportunity to share this with you. It's been a really nice opportunity, and thank you for what you're doing for us.
Thank you so much. I'll pass it on to Aryan now, who's going to talk about our future sessions.
Okay, thanks a lot. Bye-bye.
All right. Yeah, I hope you all enjoyed that talk. That was very insightful for me personally. But let me share my screen to talk about the future events that will come that we've organized. So if going back to this page with our business outline, please write reviews. Firstly, I'd like to say. Secondly, I'd like to say again, donate. Here's the a link. I've been motivated to donate more, so I'll do so. And thirdly, I'd like to draw attention to the updated website once again, like I do for the end of every session. So if you go to topics, you'll see number 4, which is mental health. So as part of Mediccom, we decided that we wanted to do mental health because we thought that people need to understand as doctors that there are certain conditions that we need to look at in patients and doctors alike. Because as we've seen from COVID, a lot of doctors have been suffering from certain mental health conditions and neglect it because they don't believe that they actually have those diseases or conditions. So we wanted to do a mental health event in order to raise that awareness and make sure everyone understands certain mental conditions. Being doctors, it's important for you to understand this too. So this will be on the 8th of August, so 2 weeks from now. So you'll have 1 week to decide which topics you want to do. And it's, again, like always, first come, first serve. And PBL presentations once again. But we might change the criteria a little bit because mental health has a unique subject matter, which is different to certain diseases that we've covered on Mediccom before. So these are the topics that we have currently that we think are around everything to do with mental health. And we might revise some and think about some in our meeting later. But please, if you want to take a topic to do for research for the 8th of August, please feel free to email us and we'll give you that position. Again, it's a first come, first serve basis, so that will be great. Next, I'd like to address the autoimmune presentations. So thank you for all your presentations today. They were wonderful. And I'd like everyone to share their presentations so I can put them here next to their topic, like we've done for our previous event, digestion. As you can see, every single presentation that we've done so far has been uploaded here. Next, the last thing I'd like to mention, going back to mental health, is we're collaborating with another non-profit organization called Health for Curriculum. And Health for Curriculum is, again, set up by another Year 12 student who I met on my work experience. And he told me that Health for Curriculum is about spreading awareness about mental health diseases and also working towards having mental health in the Welsh curriculum, because they believe that it's very important for students to understand what kind of conditions people suffer from. So they'll be working with us. We'll have guest speakers from them. They've been commissioned by certain doctors, people working with them, and they're also on LinkedIn. So feel free to add them there too. So that's all I have to say. Please donate, review, and email us. We'll keep in touch with you once again. So thank you for coming to Mediccom Event 3, and we hope to see you next time.
Thank you so much, everyone. See you next time.